to get here today. When we did our annual Cancer Survivors Day in June, it was the day of the Canadian wildfires. So this feels somewhat reminiscent of really bad weather. My name is Allison Snow. I'll be your MC today for today's event. I work as a part of the COE team. And I'm also an oncology social worker. It's really not about me. We're here for the community. So this is a little bit about our mission and our purpose in today's Cultivating Community, the ABCs of enhancing equity in cancer research, education, and outreach. We're here as a forum for discussions between diverse community, research, and education experts on how to create lasting and collaborative partnerships between researchers, providers, community, and faith-based organizations and patient advocates. These partnerships are important building blocks in making progress towards achieving equitable cancer care. I also just want to take a minute, if you're on Zoom with us today, if you want to say anything, we want you to use the chat. And there is a raise your hand function, but I think it's easier if you use the chat, and we will have people monitoring the chat. This is our agenda for today. We are going to have first panel. We'll have Dr. Parsons and Dr. Smith do our welcome and introduction. Then we'll have our panel, perspectives from the TCI community scientists and researchers. Our second panel is on recommendations from community engaged research programs. We will have a break and some refreshments if you made it here. And after our refreshments, we'll have our second panel. Our second session is outreach and community partnerships across New York City. Our first panel in the afternoon will be linking our faith-based organizations, and the second afternoon panel will be linking our community-based organizations. We hope to wrap up at 1:20, 1:30 with Dr. Smith. Now I'd like to introduce Dr. Parsons, who I think many of you know is our director of the Tisch Cancer Institute at Mount Sinai. He's also the Ward Coleman Chair in Cancer Research and director for Mount Sinai Health System and the chair of Department of Oncological Sciences in the Icahn School of Medicine. Welcome, Dr. Parsons.
Thank you. Thank you very much, Allison. So thank you for coming. And again, just to echo Allison, just in this great weather, being able to get here is really an accomplishment. It just shows everybody's really prioritization of this, I think, potentially very important meeting. And before I show my slides, can you just go to the next slide? I'll use the clicker. Yeah, I got it. Is that one of the things that we're here for? One of the reasons we're doing this is because I've been in cancer research for pretty much my whole life, since the 1980s. Since 1984, actually, I've been working in cancer research. And one of the things that's really important to understand is that the actual research that we've been doing on cancer to improve patient care ultimately has had a lot of impact. Over those years, our survival rates have improved overall. Actually, the pace of cancer mortalities has dropped overall across the country and particularly accelerated in the last 10 years. And I think it's clearly in part to in a whole pipeline of research that's occurred from the very basic research all the way to clinical trials and testing and ultimately making sure that the drugs work in all of our constituencies and communities properly. And it's not something that happens overnight, because obviously it takes decades to make progress in such a complex disease as cancer, because it's not really one disease, it's literally thousands of diseases, because there are many different kinds of cancer, and then each kind of cancer has so many different stages, how far it's progressed, and so many different molecular biomarker features that it's just, you can imagine, it's such a complex problem that solving it requires precise solutions. So I'm sure a lot of you know the word precision medicine, and really that comes out of needing to know the diagnosis in intimate detail for every person so we can identify the right treatment for them. And Another thing that I want you to know about that's really important to understand is scientists have a tendency to work on whatever they're interested in, right? I mean, that's human nature. And sometimes they get detached from what's important. And, I think that's true for all of us. We can have our favorite books or our favorite things that we want to do. But in the end, people need to get back to reality and they need to get back to home base. And what's our ultimate goal? Our ultimate goal is to improve the survival and prevent cancer for our community. And who do we need to serve most? It's our neighborhood, the place where we see patients and actually can have an impact. And I guess I should start with my slides, but point this at the screen or
Try now.
okay. So I know this is a busy slide, but basically the Tisch Cancer Institute has 178 scientists, and these can be people who work on anything from Drosophila and yeast model systems of cancer, all the way to folks working in the community and trying to change the way the standard of care is practiced and make sure that it's equitably applied. Okay, so our programs and research are divided to help make sure they capture the whole continuum of cancer care and research. We have two basic programs, one in cancer immunology, one in cancer immunology, which is really a hot area, right? We've made a lot of progress in the last 10 years in this area in improving treatments. Unfortunately, most people don't respond to immune oncology treatments. So there are some great stories where people are cured miraculously, right, with these new modalities. But unfortunately, we haven't figured this out for everybody. And in cancer mechanisms, that's focusing on the cancer cells itself, trying to figure out what's wrong with them. We also have clinical investigation, which is where we do our clinical trials. And then we have cancer prevention and control, where it's more about translating our research to the community, understanding our public health efforts in our communities, both here locally and nationally, and then also figuring out ways to prevent cancer. So the next slide. So we serve New York City. That is our catchment area. 85% of our patients are from New York City. And here are the 5 boroughs of New York City. And you can see the breakdown mostly from Manhattan, Brooklyn, and Queens. And 9% from the Bronx and a really small percentage from Staten Island. You can see, I'm not going to go into detail on this slide, but just to say that, New York City is obviously a diverse and heterogeneous place. So we have areas that are extremely wealthy and high socioeconomic status, while we have much poorer communities. And sometimes even these charts lose the complexity of the areas because there are even poor groups within these high wealthy areas, living side by side. And there are access to care issues that actually affect patient outcomes very, very prominently. And you'll be hearing more about that today. Also, there's a lot of racial geographic segregation in the city, which also plays into this socioeconomic segregation as well. And that's something we need to be aware of, and we need to understand the problems here may not be the same as the problems here. So the next slide. Actually, I'm having trouble advancing the slides.
Yeah. Okay.
So after doing a lot of work, COE has analyzed New York City's data, which is actually, we have a very strong Department of Public Health in New York City that collects data on cancer incidence and mortality. And based on based on that data, based on input from all of you, and based on what we can do well here already, we focused on these 6 cancer types, which we think are our high priority cancers. And again, you'll be hearing more about that. And here at the Tisch Cancer Institute is hopefully sort of at the middle of the circle to try to make progress in our catchment area, our New York City, for these major cancers. And also these principles that we have to educate, to engage, to discover, to translate, and to enhance equity are all something that we're always thinking about and really are core principles for all our programs. Now, that is our mission and that is our goal. Okay, next slide, please. Okay, so I'm probably running over with time, but just to say that this is an important slide, but it's got a lot of detail in it. But it just shows you how we're trying to create partnership with the community, okay? And there are really two major buckets, research and education. And this is to facilitate equitable partnerships with community members, faith-based and community-based organizations. And so these are I'm not going to tell you about the bullet points. I think you should be familiar with them and should have the slides, I think, but we have opportunities to participate in research at multiple levels here, and also in terms of education as well. And you'll be hearing more about from Cardi the processes that we're using to do that. And I think you should be aware of them. And then the other thing I just wanted to say is we're very, very proud of and also committed to our clinical trials program, which is really where we can make change, where we can study the cancers in our community to make progress in advancing improved treatments. So these are accruals at Tisch Cancer Institute every year since 2018 to our therapeutic clinical trials. And you can see they went down in 2020 because of COVID. And then we're starting to come back up, but we're still having issues because we've just only fully staffed this year our staff. And then we've had to train the staff. You can only imagine you're bringing new people, they're not going to do a good job right away, and it takes some time to learn. So we're hoping that this is going to still be a tough year for us, but we're hoping to increase accrual again starting in 2024. But one thing that's been very solid is our minority accrual has been maintained from year to year. It bounces around in the mid 40s, and it's continued even though we've had this relative reduction in what we can be able to achieve in terms of responsibly enrolling patients in trials with appropriate staffing and safely doing it. So this is where we're at. We would love to enhance this and make sure it's better. We have certain initiatives such as in multiple myeloma, where we're actually enrolling patients in Brooklyn so that we can increase our enrollment of African-American people who have a high incidence of this disease, and allows us to enroll more patients with this disease that are African-American. And this allows us to understand better how to treat that population properly. Okay, so next slide. I think that might be the last one. Oh, and just to say, we're starting in 2024 to construct our new Tisch Cancer Hospital. This is based on a generous gift from the Tisch family and also investment from the hospital, which is going to be 4 floors with 18 beds of single room occupancy beds. And it's going to have clinical research input in terms of to make sure that we can do clinical trials in this space. It's going to be, if you're familiar with campus, the KCC building, which is that white and blue building right on Madison Avenue, is going to be this building, but refacaded and fully renovated to make it modern and more appealing and pleasant to be in. Okay, so sorry, I think I ran over, but thank you. And any questions? Thank you.
Thank you so much, Dr. Parsons, for that wonderful introduction. I'd now advance the slide. It's my pleasure to introduce Dr. Smith, who is our Associate Director for the COE team. She's also Chief Medical Officer and many titles and does many things. So you can read a little bit about Dr. Smith, but.
Thank you. Hello, everyone. I just want to echo thanks to you all for braving this weather to be here with us today. I think you can go to the next slide. We at COE are really excited for you all to be here. I think as as you heard from Ramon, from Dr. Parsons, that research has come a really long way to improve cancer care. And one of the things that we've not done really well in cancer care to date is include the voice of the patient in how we do that research. And that's really what we here at COE are engaging in. And that's why we want to be here today. And I think we've lined up some really great panels to think about how can we do that better and how can we incorporate the community voice so that we can move towards equitable cancer care and cancer care delivery. And so at COE, our mission is really to work with our community to address cancer disparities across New York City, which is really our focus. And we think about that across the cancer care continuum, from risk reduction, cancer screening, through treatment, survivorship, palliative care, and or end of life, depending on what's going on with the patient. And, you know, our vision is really, of course, at the end of the day, that we get to a place where we're giving equitable cancer care delivery to everyone so that we can deliver the same kind of care to all people. We have a really amazing team, and you'll hear from all of them at some point today. So I won't introduce them too much. You can go to the next slide. And this is our breakdown. We can't do this work without our partners, our community advisory board. Many are here in the room today, and you'll hear from them on panels. They really partner with us to tell us what the needs are of the community and work with us to be able to meet those needs. We then have working groups that meet monthly and talk about how at the Tisch Cancer Institute, we can do this work in ways that are sustainable. Next slide. And Dr. Parsons went over this already. You know, the work that we do with our community is really to identify what are those needs, and then how can we take that data and relate that back to the cancers that we see in the community. And so that's how we got to those cancer identified priorities. And so with that, I think I'm going to pass it back over to Allison now, and we'll get started.
We're ready for our first panel, our first session, best practices for community engaged research. I'm going to turn it over to Dr. Mazur, and she is our assistant director for our COE team.
Great. Thank you, Allison. I think we're going to still do the slides.
Oh, still the same. Yeah.
Welcome, everyone. I really am amazed. I thought there was going to be, just the like 5-6 of us here. So I'm so impressed. Hello on Zoom. I'm not quite sure where you see me, but hopefully you can see me a little bit. I just want to give a little bit of background about like what is community engaged research, and then I'll introduce our amazing moderator, Dolores Moorhead. So next slide. Yeah. So that's us. We can move on. So what is community engaged research? This is how the CDC defines it. It's working collaboratively with groups of people who are affiliated by geography, interest, or similar circumstances to address issues affecting the well-being of that group. So really it's, bringing the patient voice in, bringing the community voice in, and making sure that we're working together. And most importantly is really this point down below. So community involvement in research is essential. It is essential to improvement of the healthcare systems and to healthcare equity. What I want to highlight is, there's community engaged research, and then there's community engaged research. How are we really creating meaningful engagement? And I came across this, this conceptual model by the National Academy of Medicine. There's a working group right now around how are we looking at community engaged research? How are we measuring it? How are we ensuring, all of these principles that we're talking about are really in this dynamic? And this is actually my favorite model that I found. So I've been looking at it lots, but what they do is they sort of talk about these core principles of community engagement. Before we have anything about health equity, we really need to make sure that these core principles, are developed and fostered. And that takes time, it takes communication, that takes flexibility. So this is around trust, co-creation, shared governance, and so on. You can read that here. And with that core principle, that's really, really the heart of how community engagement can work. This can lead to strengthened partnerships, to expanded knowledge, improved health and healthcare policies, and thriving communities. So this is really what we are aiming for as we talk about community engagement. So how are we doing that at the Tisch Cancer Institute? We recently started a community scientist program, many of them who are here today and on Zoom. Hello. So, thinking about we are developing a bridge, and our community science program is sort of this bridge between community members, researchers, and clinicians. Sort of three core elements of that bridge. We want to make sure that we're aware of what's important to the community. And that's not easy to say, but what does that even mean, community? There's so many diverse perspectives. And so really being creative in how we understand what the priorities are, understanding that our research is responsive to that priorities. I think that's also easier said than done, but working together to do that. And then making sure that our research doesn't stay in the silos of our academic journals, of our, small work in progress sessions that we have within our division. How are we sharing those findings with the community who have been involved in that process? And those are really those core elements that we're working on. Next slide. So I just want to highlight, these are amazing community scientists who we've been all working together for about a year or more. Many of them you'll hear from today, and really it's just an incredible group that we're working with of cancer survivors, advocates, navigators who have been involved with our team. And then one more. So this is ultimately, what we hope to measure and improved outcomes, that we have, increased diversity in clinical trials, equity, focused research. So more researchers, even across the basic science, that are focused kind of on equity and on cancer disparities, increased research engagement, and then, across the fellows, and then also with their community members. So with that, I am going to introduce Ms. Dolores Moorhead. If you want to come on up here. Maybe can we go back to the other side just while we all the way back. Okay, so I have been working with Dolores. She actually flew here from San Francisco yesterday. First flight since before COVID, which is amazing. I mean, and she is the community engagement director and client support clinician at the Women's Cancer Resource Center, which is currently in Berkeley, California. And that's where we originally met, and is a core part of our community science team, and has been absolutely invaluable to my work and this work. So welcome, Dolores. Thank you. And we will welcome our panelists as they come on up.
They can keep this and I'll go down.
Okay. So you're going to introduce them? Yeah, I can just maybe call them up. Okay. So.
Oh, just turn.
Now, can you hear me?
Yeah.
Great. All right. So Jean-Claude and Paulette, you're at the trap.
She's almost.
Okay, and so Travis will be joining us. And you're gonna talk about them, right? Okay, thank you.
Okay, so we have some panelists who are here in person and some are virtual. So what we'll do is I'll do a quick introduction, and then for those of you who are on virtual, just give us a minute and then we'll make sure that you come on the screen. So our panelists today are community scientists and researchers who have kind of brought community engagement to their research. We have Colette Smith here. She's a lung cancer survivor, a dispute manager for Molina Health Plan, and one of our community advisory board members and community scientists. Jean-Claude has been a volunteer at Sinai since what year?
2007.
2007, amazing. Still going once a week to Rettenberg. And is a prostate cancer survivor, a co-investigator with Dr. Nihal Mohammed on her impact study, and of course, part of our community advisory board and community scientists. Chaplain Travis Thomas, she just parked, so she should be coming in any second now, but was harrowing this wild rain. She is a 3-time cervical cancer survivor, founder and president of Save for Life Cancer Corporation. She's a cancer patient navigator and a community advisory board member and community scientist, and she actually partners with me on my access study, which is an NCI funded study around equity and supportive care. And then the next one. And then our 3 researchers, we'll have Harriet can come on up. Thank you for coming in person. So we have Dr. Amir Horowitz, who, hello, I'm sure you're on there virtually. He's an associate professor of immunology and has been doing kind of our first person that we've been working with in cancer immunology, really doing sort of community engagement. So excited to hear from him. Dr. Harriet Mather is assistant professor and attending physician in geriatrics and palliative care, and also does a lot of work with community engagement. She'll be telling you about that. And Dr. Jamelia Sly. Hello. Who is an associate professor in population health and the associate director of diversity, equity, inclusion, and has been working in community psychology and community engagement for all of her career. Yes. Welcome, everyone.
Thank you, Melinda. So we're going to hear from the community scientist first, and Travis, when she comes, will bring her into this conversation. So there's a few questions that we want to ask. I'll have to remember to hold this here. And so I'll start with you, Jean-Claude. So tell us a little bit about how can researchers and their institutions best ensure the community scientists are integrated into the research enterprise?
Well, I think one proof of the integration is that we're here. So that's a recognition of being actually part of what is going on in the institution for a number of years. So we get the support. Creating community scientists was a sign of support. It's also what is important is the awareness that we exist as community scientists. And it has happened over the last couple of years. We've been in touch with a number of clinicians, researchers who are now more aware that we're here and we can be used as a resource, which is really what we are as community scientists. We have no authority. We have hopefully some influence, but no authority. But we are a resource. At a collective level, I think it's important for researchers to understand that they can draw from different profiles. We're all quite different. We have different profiles, different experiences, different skills, different competencies, different cultural backgrounds. And we actually learn from each other as a community. And I think others can also learn by the interaction we may have. And at an individual level, it's important to recognize it's not that every one of us is good for every research. It's important to identify the fit. Is any one of us the best fit for that particular research? It's important to identify what value we may be able to bring. Sometimes we can bring value, sometimes not. And also, it's important for us to have some level of alignment with our personal interests, because that's what creates our motivation. As an example, I've been invited, and I'm grateful to have been invited for a research for active patients under active surveillance, the impact study, which was mentioned by Melissa. And that's the best opportunity as a co-investigator. I can be part of the research from the beginning, from the design, the submission, the actual holding of the research. And that's a good opportunity to actually translate the research in practical terms. This specific research is focused on addressing stress levels, anxiety, which patients, prostate cancer patients under active surveillance are going through. As when they're not treated, they have cancer in their body and feel sometimes that they would like to be treated rather than wait. Or in reverse, they might also be very happy that they don't have to suffer the consequences of treatment eventually, but they go back and forth. So we feel that this study will help them find the right coping mechanism. And it's a typical study where it's not just about the study, it's about the intervention. It's actually, we'll have 50 patients, and these 50 patients will benefit, but it will go beyond that and will be an intervention which can evolve beyond this first group and actually to other types of cancers. So that's kind of one opportunity where we can be integrated, and we appreciate being integrated.
Well, thank you, Jean-Claude. So you mentioned about individuals' personal careers and goals. And one of the things we'd like to hear about is how can we facilitate and create opportunities for community scientists to use their skills?
Yes, you have already by the institution, by bringing us, by actually asking us to become community scientists, has already achieved that. And this has created actually what is really interesting for me, what I'm passionate about is be with a group of people I can learn from. And we're learning from each other, we're learning from this group. And that cross-learning is extremely valuable. We're learning about each other as people, and we're learning about our respective experiences and knowledge, and also as patient advocates. So we're getting that support, which has been materialized in different ways. One was the Community Scientist Institute first course, which took place earlier this year at City College. That's a Disrupt initiative with other institutions, Columbia, Einstein, and Mount Sinai. This was a great opportunity for us to go beyond just basic awareness about cancer research, but starting to understand a bit more the methodology about cancer and clinical trials, and be able in our interaction with researchers to actually be more valuable because we understand a little bit better what is being done. So that was a very valuable experience. There is also a qualitative research course, which is organized regularly here at Mount Sinai, which many of us have benefited from. So that's also a good opportunity. Then there are outside many opportunities within Disrupt, but also run by other institutions, which we can all attend. And all of this is part of our development. And really, it's not so much about career, at least not for me. I'm at a stage of life where it's not about my career, but it's still at a stage of life where it's about personal development. And that's really what this is for all of us, I think. It's an opportunity for personal development and recognition, which is also part when we do this type of work. It's important to be recognized, and we are. And I always feel that because of this, I've been able to do things I would not have been able to do otherwise, and things I was not even aware I could do. I was not aware I had the potential to do things I'm doing here at Mount Sinai. So I'm very, very appreciative of that. And it's a rewarding human experience at the end, which we benefit from, and hopefully patients, researchers, clinicians also benefit from. So that's kind of my view on career.
Thank you, Jean-Claude. So Colette, how can researchers best collaborate with community members to communicate research results to communities?
Good morning, everyone. First, I want to say I am so grateful to be here. I just celebrated my 8th year anniversary of lung cancer survivorship. Go back to me. So I'm happy to be here. So how can researchers best collaborate with community members to communicate research results to communities? I say, meet us where we are. Get creative, form relationships with organizations and institutions that we trust, and such as faith-based institutions, community board meetings, barbershops. I trust my hairdresser. Find her and give her the information. And if she gives it to me and others, we trust it. So that's how I would recommend that information be disseminated.
Okay, so since Travis hasn't arrived yet, do we want to open it up for any questions that folks have, and then we can integrate Travis back into the conversation? Yes, Dr.
I have a question. Is with the Disrupt meeting, the first one was at City College a few years ago now, and at it they announced that they have developed a community scientist training program. I was wondering if anybody could give an update on how that's doing. I haven't heard about other than that first time.
I can. It's Nina Bickel. I'm the PI of Disrupt.
Oh, okay.
So the community scientist program is now a certificate granting program at the City College of New York. As Jean-Claude said, it's the collaboration across the 4 institutions of Sinai, Columbia, Einstein, and City. And in recognition of the importance of the input of community scientists and the need to really help develop and encourage voices so that we have community input into future research, this program was started. It happened in January of this year. It was a 6-week program. Because of feedback from the participants, which was overwhelmingly positive, as we heard from Jean-Claude, it's now expanding to an 8-week program, and it will happen again, I think, this coming January as well. It's a hybrid. We prefer if individuals can come because, and Jean-Claude, you should talk about this, but I think there was a lot that was gotten by being in person. And I think they were in the midst of talking about opening it up to a broader audience that was beyond our catchment area. But I don't know that they've come to a decision about that, but that should be happening. And I think that the application process is open now. You can go online. The Disrupt website is www.stopcancernyc.org, I think. Yeah, and that should give additional information.
And also, I know both Dolores and Jean-Claude attended, as well as some others. Maybe you just want to share your experience.
Yes, I felt very honored to be able to attend from California. It was hybrid. I was on Zoom at 6:30 in the morning. It was definitely worth it. I really appreciated being able to participate and also to do our final project. Those of us on Zoom were able to get together and present. And I learned a lot, and I appreciated hearing from everyone. And I also got to learn a lot about what's going on in New York. And I thought, okay, I'm in California. How will this work? But what I learned also can be translated into what I can do in California and my work in cancer. So I appreciate it, very much appreciated that opportunity.
We just added, created a community of alumni as well, which were the first group, but there will be others. And this is amazing how we've been able to interact. And the project, actually, the faculty was spectacular. We had really access to faculty, which gave us not just the knowledge, but the opportunity, the exchange. And this was also a trust building exercise, I would say. And the project, actually, in my case, the project we had in my group materialized. This year is Prostate Cancer Awareness Month, and I was involved in multiple activities during this month as a result of shaping that particular project back in at the college.
So welcome, Travis.
Yeah.
I swam here. Well, we're glad you were able to swim and stay dry. Change clothes, change clothes. So, you're the person that we have a question for us. Others have spoken. So, you want to take a deep breath before we start?
Oh, no, let's just go.
Okay. All right. So, Travis, what are the important first steps to building relationships with communities?
Okay. I believe that the first steps to building relationship with community is establishing trust. Trust and comfort and actually being a part of community as well is very important to establishing that relationship.
Okay, the next question is, if you can go further in.
Okay.
Explain importance of forging reciprocal relationships between the patient advocates and researchers. And also, what recommendations for how to develop and sustain these relationships?
Okay, you really went in, right? Okay. A deep breath, right? Okay. Can you repeat it one more time for me, please? Okay. Mhm.
Okay, now that you've taken that deep breath, of
Uh-huh.
course. Okay, explain importance of forging reciprocal relationships between the patient advocates and researchers. And with that, add any recommendations of how to develop and sustain those relationships.
Okay. Love you, Dolores.
Have to make sure that that there's sort of equitable relationships between community partners and researchers. And it really is shared.
Okay. For me, from my experience, I believe that how to make those relationships with community and researchers are actually seeing the researchers. It's not enough for you to be inside medical facilities located in clinics or hospitals or research departments. We do appreciate you. Yes, we love all of you. But we really need to actually see you. We actually need to know who you are because of all of the myths. Your face looks like someone who is out to hurt us. I'm speaking on the side of a community member now. Okay. Just hearing the word research is something that we fear. And for you, you are like that person that we really don't want to come in contact with because we don't know you. So it's important that you let us see that you are a person. Researchers are people. They are people that they want to know more. They want to learn more from us. They also want to help us to live longer. They're not interested in treating us like guinea pigs. They really do care. And so I believe that that's one of the most important parts in establishing a relationship between community and researchers that you're seeing. And to somehow develop that relationship of trust within that community, whether you come out once a month or whether you come out, at one point in time, you are setting up ways to actually meet the community. Whether you're doing it virtually, that's good too, but don't stay online too long. It's good for you, but at least have that face. So we know that, you are not what we thought you were, but you are so much more than that. And you mean so much to the community as researchers as well. Sorry. Second question again.
I think you answered.
I did. Excellent.
Okay. Thank you, Travis. Thank you, John Claude. And thank you, Colette. So I'm going to move to the researchers. And so I will start with Jamila. So how have you built deeper relationships with communities? And what are the first important steps in building the relationships with the communities as a researcher?
Yes, I think that I'm happy that I went after you, Travis, because I think that I'm going to build off of what you spoke about. And I think that in my experience, how we build deeper relationships as researchers is to do exactly what you said, to show up to communities and not that you're a member of the community, but I think it's important that you participate in community events where possible, and just show yourself as a human in a lot of ways. And I think that goes a long way towards building trust so that community members can get to know who you are. Not they don't have to know all your business or anything, but I think it is helpful for community members to see you in a different light, not necessarily in an ivory tower, so to speak, but if you attend events that community members may be having, I think that goes a long way and it speaks to the respect that you have for the community and the care that we have for community members. So doing things like that, I can give an example of the ways that I've built relationships with some of my community partners in the African immigrant community. During the summer, there are so many events that happen throughout New York City. There's festivals, things like that. And there are events that are germane to the African immigrant community. So there was a Ghana Day festival. There's a lot of things that were happening and we just showed up and were participating in those events as community members, even though we were representing as folks from TCI and Mount Sinai. We didn't come to necessarily ask for anything, but we came to show support for these different events. And so if you think about it in that way, it's like, oftentimes community members can see us as asking for things for them. We want their data, we want it for our research projects. But how are we giving back to them and to the efforts that they are participating in or leading? So I think doing things like that can go a long way towards building those kinds of trustful and deeper relationships.
Thank you. So glad to meet you.
Thank you, Jamila. So, Amir.
Oh, he's in Norway and he's having connectivity issues.
Oh, okay.
Let's move on.
Okay, thank you. Okay.
Try and be a myth.
What can we do better as an academic institution when working with community members? And what approaches would you like to take or have taken to engage members in research?
So I think what we can do well is what we're already doing here today, which is sharing an explicit commitment to working with communities. And I think what we really need to do is to support this work beyond individual projects. This needs time, it needs money, it needs resources, and it needs trust. And all of that takes a lot of time, but it takes institutional support, as is happening here, beyond individual projects in a sustainable way. And I think that's critical to what we're trying to do. And I think, as Jean-Claude mentioned, we need to really aspire towards working with community partners at all stages of the life cycle of a research project. It isn't just kind of, can you look at this survey? What do you think? What do you think of these results? It's kind of like, what are the questions that are important to you? What matters to you as a community? And how can we together think of ways to answer those questions? And so that's the conceptualization of research questions. It's grant writing, it's study design, it's data collection, it's interpretation, and it's dissemination. And that has to go beyond involvement and consultation, more towards shared decision-making. It is about having shared authority over the decisions that are made within research. It's not about, I don't have any authority. It's, we both have authority over the decisions that are made here. And I think that's really critical. And I think kind of related to that, and a lot of what we talked about today is about co-learning, learning from one another. And that takes humility. It's about building capacity for research, sure, but it's also about building capacity within research organizations. How can we be doing this better? How can we learn from you? And how can we learn together? Because only in doing that are we actually going to kind of come up with these solutions together, and are we actually going to get things which actually can be implemented? And that all relies on what we've talked about so much, which is trust. It's showing up and it's trust. Trust in one another and being open to who we are and what our motivations are and what we can learn from one another. And I think this word humility is critical in all of that. And in terms of approaches, I think just kind of following on, I think we need to be moving towards deeper partnerships between academic institutions and community partners at all stages of research, and thinking really about what do we need to achieve that goal. And that might need more creativity in kind of how we fund research. How do we allocate research funding? Do we allocate it to institutions, or do we allocate it equally to community organizations? And how do we think about building research capacity within communities so that we're in true equal partnership? And that's what I would like to see. I think from my work as a kind of palliative care physician and a geriatrician, I want to think about how we accommodate engagement for people for whom that might be a particular challenge. People who maybe can't get out of their home, people who are caring for loved ones and having to do 100 different things at once in their life. How do we make our engagement approaches inclusive of everybody? And I think that's really important as we think through this. And then as a kind of earlier researcher, I want to think about opportunities for matchmaking. You know, community-based organizations, what research interests do they have? How do they want to partner with us? And where can I go to kind of understand who's out there and what the landscape is? Yeah, that's showing up in communities, that's being part of communities. But I think having that kind of matchmaking in some kind of central place would be amazing. So yeah, those are just some of my thoughts. But to echo what everybody has said, I'm so grateful to be here today with everybody. Thank you.
Well, thank you, Harriet. I really liked what you and Jamila said, and I love the idea of matchmaking. So I see that there are some questions that were popping up on chat. Okay.
So this is a question from Jody Stein from the chat. She asked, how do you see the role of CHWs, I assume that means community health workers, in recruiting people for research studies?
Can you repeat the question? That's not.
You're back here.
How do you see the role of community health workers in recruiting people for research studies?
Did you hear it?
Yeah.
Okay. All right, so anyone on the panel can answer.
Oh, I need the mic. I believe that one way how we can do that is educating the community. And I think along with researchers, we need to do the same thing, educating them as they come in, giving them information about what is research. There's parts of research that we need to know to get a better understanding, working in the medical field, when we're talking to patients and clients and community, is that what is research? There's different types of research. There's different ways you can participate in research. It's not all about just experimental, but there's different ways. I think educating them on what research is and having that conversation. Are you interested in research before it's too late, and not waiting until it's the last minute and that's your last resort is really important for all of us, not only community health workers, but everyone who's in this field, researchers as well.
I was just going to chime in and say that I think that I know for myself and a lot of colleagues, probably community health workers are really important components to the research that we do. They serve in a lot of different capacities in research. They're really important to recruitment and to survey administration, a number of different things. And so I think one of the values of having and including community health workers in research is that a lot of times community health workers come from similar backgrounds and communities as the people that we're interested in engaging. And so there's something that's built in to a certain extent, a certain level of trust that is there, where it makes it easier, I think, perhaps to talk to someone who looks like you, may come from a similar background when they're asking maybe really intimate questions and things like that. So I think that the community health workers serve a really integral role in research. And I also think when we're talking about diversity and inclusion and how we can expand that in a lot of ways, that can be a really nice entry point for people who may not have taken similar paths to those of us who are, PhDs and we have all the degrees behind our names. Community health workers can be really integral in that, and it can be a nice entry path into clinical research, perhaps. I don't know if anybody else.
I would just add one thing, which was reflected on one of Dr. Parsons' slides, which is the last phase, which is how do you translate research to communities? That's also part of this cycle, because when you have the opportunity to do that work of education, after a study has been done, it also builds that trust, it builds that relationship. So it's not just at the beginning in terms of the recruitment, which is obviously very important, but it's throughout the process and at the end, sort of building that interest in communities about what does it mean? What does that research actually mean to me as an individual or to us as a family?
In addition to what everyone else added, and I'm going to relate this all to my experience as a patient. After having my surgery, it was important for me to find someone in a space where I could trust and have open conversation who had a similar experience. So if somehow researchers can connect other patients who have also gone through the clinical process and connect them with patients who are at the start of their process, I think that will be helpful. And that's based on my experience. I want to see someone who looks like me. I want the exact diagnosis, the exact stage, and I want to know how that person did it. So that would be important as well.
Thank you. Thank you, Colette. I think that's really important.
Yeah, so we have another question from the chat. How do we measure trust among our community members?
I think the question is, how do we measure trust?
How do we measure?
Yeah, measure.
Oh, okay.
Okay, does someone want to answer that? And this is unfortunately, it's going to be our last question. So, can you pass the mic to Harriet? Thank you.
I don't know whether this gets to the kind of root of that question, but I would like to kind of pick up on what Melissa was saying right at the start, which is, I think we need to be very thoughtful about how we're measuring what we're doing in terms of community engagement. You know, what are the most effective ways to be partnering with communities? How do we begin to measure the impact of what we're doing? And I think that's really important because there are skeptics out there. And there shouldn't be, but there are. And there are people who are saying, well, what's the impact of this and why is it necessary? And I think it's really important that we collect data on that so we can demonstrate that. And we say, this is why it's necessary. This is why it's important. And so trust is part of that, but there's so many other aspects to building relationships with community partners that we need to be able to measure and we need to be able to demonstrate because that's the world in which we live.
I think that we can also measure it by speaking as a oncology patient navigator and a 3-time cancer survivor, is to, as we go out into the community, the different populations that we, as well as taking the data from the different ways that we reach out to community, different ways we actually reach community, whether you're in projects, whether you're in nature, whether you're at community events, and measuring how many, the people that you meet, how they feel about research, taking those surveys is a great way to measure it, talking to each one, doing tabling. There's everything that you're doing within that community that is in contact with the community, whether it's taking phone calls, whether it's in part of oncology patient navigation, helping out with research, or other members in the medical field working out with research, connecting with community. And as you do that, I believe that just keeping count of everything and who you're reaching and what are their responses is a great way to measure whether it's going well or whether it's not going well, whether they're interested or they really want you to leave. But they'll never do that to you. Yeah, I think that's very, very important. And thank you so much for that question to the chat.
So, this is the end of our first panel, and I want, if we can thank everyone for being here. And I'll say thank you, and it's really nice to see each of you in person.
Thank you all so much. I wish I realized I think we should do our next retreat in Aruba. So then it'll be sunny and we can have the entire weekend. We don't have to feel rushed. So I'm sure that Tisch Cancer Institute will support that. So I'm very excited to introduce our next panelists. These are researchers who have run community engaged programs, whether they're community scientist programs, community advisory boards, and engaged with patients and really kind of understanding, I think, from the researcher side and also sort of the programmatic side, of how do you make this work at your institution and with the community. So I'm pretty sure, I don't know who is actually here in person. I think we have one person in person and the rest virtual. Okay, so I will introduce Dr. Abigail Beim-Lantz. You get to be our solo in-person panelist. She is assistant professor of the Department of Geriatrics and Palliative Medicine, also health service researcher, and does a lot of community engagement with the VA. Also virtually, I think we can spotlight. Oh, good, wonderful. And Dr. Nina McKell, as we did hear from her earlier, thank you. And she is a co-principal investigator of the Disrupt Grant, a professor in medicine, and many, many, many other leadership hats, including the co-director of the community engagement core at Sinai. We have Janet Brish, who is here from University of Florida. So thank you so much for joining us. We actually spoke to her when we were thinking about developing a community scientist program here, and they had a really wonderful website and we're sort of formative in that and the guidance of how we started our program. So thank you. So she's the manager at the University of Florida Citizen Scientist Program, and also many other roles there. And then we also have Crispin Goita. I think she is on. Zoom. Okay, great. She is the program manager for Institute for Health Equity Research, principal investigator of the Insight Network, and a part of many other community engagement committees. So thank you all.
Oh, wow.
So-
Okay.
Yes. Well, we're gonna get started and you and I get to be here up here by ourselves, so we'll just have to make it exciting. So it's really nice to see everyone who's on Zoom. And I'm gonna start with a question to Crispin. And that question is, what are the greatest barriers in bringing the patient voice into research, and how did your programs overcome those challenges?
Hi, good morning, everyone. Thank you for having me, and sorry I can't be there in person. Flooding and weather make it really difficult sometimes. Great question. So there are quite a few. Can you hear me all well? I just want to make sure. Okay, great.
Yes.
Wonderful. So there are quite a few barriers and challenges when thinking about engagement and working with populations and with groups. And some of the biggest barriers could be some things that Travis just alluded to, and others, that there are times where there are just trust issues and we have to develop rapport and trust with the patients and the partners and the groups that we're working with. And I think that honestly, breaking down, building trust and breaking down that barrier has been probably the single most difficult thing I've had to do in working with different groups. And I would say that spending time learning, working, active listening is very, very important for me and for others to really understand what the lived experience is, what the set of expertise that people bring to the table. And when people know that you're genuinely listening to them and paying attention to their needs, that resonates so well. I mean, think about ourselves. If someone is not paying attention to us, if someone is not giving us the respect that we feel that we deserve in that moment to share whatever it is we're sharing, whether it's in our personal lives or professional lives, we feel like people are not being genuine. So the more that we can connect with people in a genuine way, explain why we're there, being transparent, how they can help us and learn, and listen to sometimes when they have feedback that may be very uncomfortable for us. That's really important and very helpful. And so all of the programs that I've worked with and the efforts that I've worked on have really honed in on how to make a person feel like an individual and part of the group and how they can contribute.
Thank you, Crispin.
You're very
So,
welcome.
Nina, go ahead. So, Nina, which approaches have been most successful for community members, and also which ones have not worked?
So first, thank you for having me. And I am remote, mostly to keep folks safe from COVID. But first of all, Crispin, just spot on. So part of it, I guess, the place to start for somebody who wants to start working with community, we're very lucky at this point in time because there have been a nidus of people in the institution who have been working for decades in community with community. And so it's really helpful to get connected with those individuals just to start learning how to do it and start making connections within community. I think the points that have been raised both in the prior panel and what Crispin said is, you know, there's really no replacement for being there. I think that being there shows people that we respect them, that that requires not just only being there, but the active listening that Crispin was talking about. I think one of the key things that has been important in being able to do work with community is the importance, as in a physician-patient relationship, of identifying what community's agenda is and what your own agenda is, and bringing those to the forefront so that you can really collaborate and negotiate effectively to come up with something that really will work for the benefit of all. And you know, that actually is very challenging to do at times. When we were putting together Disrupt, which is diversity and inclusion in scientific research underpinning therapy underpinning trials, you know, we started out at the very beginning working with patient advocates and community members to see their perspectives, what was important to them, how should we be doing this, what should we be doing, because that's critical. You know, as Dr. Parsons talked about before, you know, researchers are off doing their own thing, which is critically important. But, you know, we created all these COVID vaccines, and for a long time, nobody was taking them. And it's a recognition of the importance of both identifying what's important to community and really developing the trust. And the way that you do that, I think, is through that, what Crispin was saying earlier, of that active listening, of identifying the agenda, of addressing the agenda, and of doing it together where everybody's voice counts. I don't think there's a way around that. I think that takes time, and I think it takes follow through. And you can't just parachute in and expect things to happen. That will just backfire and reinforce all the negative and existing, rightfully so, mistrust that we've encountered that has been developed over years and years and years. I think one of the other really important aspects is you got to pay people for their expertise. You know, we pay the scientists who are part of the advisory board for the Cancer Institute. You know, we should pay the community members for their time and expertise when they're working on different projects. I think it's a sign of respect and of value. And I think that the NIH has become more aware of that, thank goodness. But I think these are some of the basic building blocks of really being able to develop effective relationships and ultimately work that hopefully will benefit the entire community and not just parts of it.
Thank you, Nina. So you brought up some really good points, Nina, and I'm going to go to Janet to share some success stories and how it's impacted the patient and research outcomes.
Yes, thank you. Good morning, everybody, or I guess I'll say bonjour from Montreal, where I'm here at a conference. Thank you very much for allowing me to participate remotely. I really appreciate it. I do just want to quickly note, I work with our UF Health Cancer Center Office of Community Outreach and Engagement on the educational development of curricula for our citizen scientists. I'm not currently the one managing the program. I used to. And I will say the team currently managing it is doing a fantastic job, really bringing our folks onto more cancer-focused projects in our newly NCI designated cancer center. But I was so happy to get this question in the list because I love telling this story from when I did manage the program. Back when we created the first curriculum on clinical research that Melissa mentioned earlier, one of the things that was happening simultaneously was that we were one of the national recruitment sites on the adaptable study, which was about aspirin dosing. And our cardiology clinic had their recruitment plan where folks would come in for their clinic visits. They'd talk to their doctor and they'd take the information home and log online to the website and self-randomize online. And they just were not having much luck with that. The recruitment was lagging. They couldn't figure out why. And so they asked if they could meet with our citizen scientists and just sort of pick their brains about it and see, you know, if they could offer suggestions. And so we had a summit and we actually videotaped it for the curriculum. So it worked out really well. And as they were going through their struggles, one of the citizen scientists raised her hand and said, have you considered the fact that a lot of the people in this area don't have internet at home? And I mean, you could just see it land on all of the researchers' faces, all the clinicians' faces. Oh, it didn't occur to them because that wasn't their reality. Our catchment area is 23 counties in North Central Florida. And of those counties, half of them are considered economically distressed rural counties among all the 67 counties in the state. So, you know, we serve a very specific population, and not a lot of our catchment area has Wi-Fi at home. So the researchers, based on that one, what almost seemed like a throwaway comment to her, I'm sure, they went back and they rethought their strategy, and they changed their strategy for enrollment and recruitment to come into the clinic. Here's an iPad. Enroll here right now. We'll help you. And the entire trajectory of the study at our site changed. It was a very successful study at our site just based on that one concrete piece of feedback. But I think it's a great anecdote to show how we really do get into our ivory towers, and we need to break out of that. And that's what we need our community members for. And, you know, as Nina mentioned just now, it's important to pay the community members for their expertise. We do that as well. And I also heard at a previous conference, the Academy Health Annual Research Meeting, one of the speakers was saying that they work with a community member whose outgoing voicemail greeting says something to the effect of, you know, if you're calling me to pick your brain, you're calling me to pick my pocket. So please be prepared to deal with that, which I thought was just genius. Because it's true. How often do we, you know, need that perspective? And, you know, we don't want it to be a one-way relationship there. We have to recognize them. And I think that we've seen some real success at our site based on that approach.
Thank you, Janet. Abigail, this question is to you. So I feel like we got wonderful comments from Crispin, Nina, and Janet. And so your question is, what surprised you most about community perspectives on research?
Yeah, thank you so much. And thank you to the panelists and all of these fantastic experiences and thoughts. So I am a medical anthropologist by training. So the way that I conduct research is sort of inherently very oriented towards engagement and participatory approaches. And it's been really a pleasure to find a way into both more of that through research, and then all of the infrastructure and all the process work we try to do around research, to do research in a way that's really in a kind of co-partnership with the people that we're hoping to better understand and help and care for in our healthcare system. I come from, so I'm a faculty at Sinai, but my primary sort of the time where I really spend my day-to-day is in the VA in the Bronx. And the VA has actually made quite a substantial commitment to advancing models and tools around veteran engagement, veteran and caregiver engagement, resources, and then infrastructure development across the VAs across the country. So at the Bronx VA, I started in 2019, just pre-pandemic. There was an interest in our geriatric palliative care group to stand up a veteran engagement group, which was the first of its kind in our VA. So of course, it's sort of a contradiction in one way, very much a part of trying to build research in a collaborative way. And also we're kind of in an infancy state in many VAs, and there's a lot of work to do. So we've gathered about 10 individuals. We're entering into our 4th year of having a veteran consul, veteran and caregiver consul. And it's been one of the highlights of the work that I've done with the group. And I think that, so we had a meeting last week, which was really well timed, and I brought some of these questions to the group. So in terms of things that have surprised me, these are both my perspectives and also gathering from their thoughts. For me, I think over the few years, one thing that has really stood out is in all the research projects that our group hears about, certainly the drive is to have their input into the projects themselves. But I think there's a real interest and hunger in learning from these projects for all sorts of very personal reasons. And in our sort of reflections year on year, our members talk about the learning they've done, their curiosity being sparked, their sort of sometimes taking ongoing steps outside of our group to learn more on certain topics. If they're hearing about Alzheimer's disease and related dementia, if they're talking about, and I think that came up in the first panel around the sort of personal development side. And that was a piece of it that I hadn't anticipated would be so important to the process. And I think is very important for researchers to realize that, this is really bidirectional in a lot of different ways, and that there are sorts of different kinds of interests there. So I think that was something that struck me. And then on the side of the group, we are a work in progress. And just to be, really candid, this work can be really tough. What I heard last week was really wanting researchers to really develop their projects with the insights that they hear from our group, and that the group wants more information about how what they learn in the group gets implemented and steers, the ship around the future of research. And I think there's much more we need to do, and maybe me in this kind of facilitator role, more I need to do to help us, sort of communicate that message and help sort of hold researchers to be accountable to the expectations of groups. So those are some of the things that I'm constantly learning. It's a constant learning journey for all of us, I think.
Thank you. So we're going to move into here recommendations. And so the first question is to Nina and Janet. And it is, how can institutes encourage researchers to create community partnerships to bring in the community engagement piece?
Janet, do you want to go first? You want me to go first?
Yeah, I'll go first. And I'm sure we probably have some of the same ideas here, but I think getting buy-in from leadership is very important. That'll make implementation a lot easier. And then treating it as a long-term investment. Good partnerships take time, and it needs to be viewed as that. I also jotted down, I think it's important to get to know the community. I think Travis was saying earlier, be in the community. We actually didn't realize that the term principal investigator can actually be met with skepticism, because the word investigator sounds a lot like police. And, that makes some people reluctant to participate in studies. So just by making those connections and having those conversations, that actually was a piece of feedback from one of our citizen scientists. I believe I saw him logged in. So thank you, Stan. But by making those connections, we learned a more effective way to communicate with, the community around us.
Yeah, I agree with what Janet said. I think that one of the most critical pieces that has to be recognized by institutions is the amount of time and effort that it takes to not just develop these relationships, but to maintain them. And that tender loving care has to be acknowledged. And I don't think that it actually is. And one potential way to do that is it could be recognized as one of those critical accomplishments that we as faculty, as researchers, as we go up for promotion, that could be one of the components. Just as clinician educators get evaluated on different curriculum, researchers who are doing community participatory and community-based research, well, participatory, because that's one that takes a lot more time. That should be recognized and acknowledged, and count for towards the bean counting that's required for ultimate appointment and promotion. So that's one potential thing that institutions can do to really help support and encourage community participatory research. I think that the NIH has come a long way in acknowledging the import of community. There's been a huge recognition for years that I'm sorry, I'm just reading chats. It's just, I'll turn it off. It's distracting. I think that, there has been, slow but steady, and more recently more rapid recognition of the import of community, because it's just like in medicine. You create these guidelines and so what? They just sit there. It's like there's an app for that. unless you really are working with people to get things to happen, it's not going to happen. And so finally, NIH has been putting their money where their mouth is and is starting to invest in this. And really the only way that we are going to be able to improve the health and well-being of the community, of all of us, is really by doing this together. And I think that institutions have to recognize that and support that. And, and I mentioned some of the different ways that they could do that.
Thank you, Nina and Janet. So the next question is to Abigail and Crispin. What is the best practice that the audience can take away on how to successfully engage in a community, engage the community in a research project?
I don't know.
Go first.
Yeah, that's fine.
Oh, okay. I want to steal many of Nina's suggestions as best practices. I think we should all be doing a lot of that. I think the institution building piece is so important. And I guess maybe, and the idea of long-term relationship building and really trying to communicate the value and really the imperative of this being long-term work. Within the group itself, I think we've been focused on developing shared purpose and really reflecting regularly on what brings us together. Why are we all here? What are the common denominators that link the members of the group to be able to kind of work together towards contributing their ideas in an open way, that there's shared trust, no matter where people are coming from. And I guess I would just say from, again, my sort of facilitator role, I am whenever I find colleagues, like-minded colleagues, like even in, coming here today, this has been facilitated by finding folks in the Sinai system who have a sort of shared vision, a shared belief, just like become like glue, just the network of allies is so important to be able to together advance sort of these shared goals. So I think, attending whatever sessions and really being very much out there with the kind of work we're trying to do together, and leaning on each other and the work to advance it is really important. Kristen.
Great. Piggybacking off of what everyone said, Abigail, that was really important, Nina and Janet. I have to say that it's not a best practice, but best practices, right? And also what may work for your community or the people you're trying to work with and populations and groups may have to be tailored, a different approach. So I would say to be open, active listening, thoughtful, respectful, and understanding. If you can think about those things when engaging with individuals, that will take you a long way. And I think that those are key pieces that kind of filter into everything else that was said today.
Thank you, Abigail and Crispin. So our last two questions are going to be about dissemination. And I'm sure that everyone in research knows that dissemination out into the community. I know from my 34 years of being in cancer, working with the community, that the biggest thing is that you come into the community and you don't bring it back and people feel used. So our question to Nina is, how do you share research results with community members? And that's for Nina.
So I'm actually going to, I hope I'm not breaking etiquette rules, but I want to bring Zarina Costello in on this because she's held my feet to the fire when invariably in research, things seem to happen way slower than you anticipate. And so then you get involved in other stuff. And this is all bad practice. And unfortunately, it ends up with not sending results out to the community. But Zarina kept on me saying, you have to feed this back to people. You have to tell them what you found. And so I'll answer this quickly and then I'm going to turn it over to her. What we've done in Disrupt is And Zarina's been leading along with Bruce Rackin and Parisa Tenapart from Columbia. Bruce is at Einstein, the engagement in community, but that also involves the way that we're going to disseminate results, so that it does not become one of these approaches of, oh, get right in there, got what we need, and then, how to move on and just kind of drop the ball. So Zarina, you want to talk about the work that you've been doing and the different kinds of meetings and how we can use those for dissemination?
Good morning, everyone. Dissemination of information, whether it's results from data that's been collected, should be in the context of the overall relationship with the community, so that dissemination does not become something that's separate and apart and an afterthought, but should be planned from the beginning of the project, so that the information can be disseminated in a timely manner. Given that it has to go through various steps before you get the results often. But yeah, so wherever we have been, we've had this bi-directional conversation and ongoing relationship with the community. Their questions are integrated so that we make changes along the way in the way we approach working with the community, and even in relationship to the research project overall. So with Disrupt, we have had this opportunity, and really the community is great. They are so enthusiastic and want the information. And so that makes, they hold our feet to the fire. So it's not so much, Nina, that I was holding your feet to the fire, but in response to the community being held accountable for that dissemination of information and ongoing dialogue is very important. So we will continue to do that and make our best effort towards that. But I think planning it within the context of the overall project has to be a forethought, not an afterthought.
Thank you, Nina and Zarina. So this last question is for you, Crispin. How can the community find out about the type of research being done in their area?
So great question. And there's so many ways to do that. And I think the most important thing is for people and communities to feel empowered to understand and ask questions. And we've seen that with COVID as an example of how people had to learn very quickly nomenclature, what things meant, what does this mean, what is a phase 1 trial and a phase 2 trial when talking about clinical research. And it kind of bumped up a lot of people's immediate knowledge on research in this very unanticipated way. And I think because of that, we have to be respectful of that there's different learnings and understandings across communities, and that institutions and organizations have to understand that different types of people are going to ask different questions and be somewhere along that spectrum of understanding. And I think, honestly, having communities go to trusted gatekeepers, spiritual leaders, community leaders, those individuals will be the ones that are often involved in research projects, as Nina and Zarina just alluded to, and talking about our community partners in Disrupt and other projects. And I have to say, that's really important because often they'll be the individuals that give information to communities and people who are interested. And so it's not just one place, but it's thinking about how to empower people not to be afraid to ask questions, and having available trusted resources and people and communities to be able to help answer or find out where to get these questions.
Thank you, Crispin. So we're going to open it up to any questions. Oh, lots of questions. Okay.
Go ahead, go ahead. Yes,
This question is for Dr. Parsons, Dr. Smith, and all of the other clinicians here. And it's in regards to screening guidelines. specifically as they pertain to lung cancer and policy changes. Oh, thank you. How much of that did you hear? Okay, you heard it. So, as a lung cancer survivor, I'm very aware of the policy with regards to screening. And oftentimes it's associated with a particular behavior, smoking. I don't know that that's transferred to any of the other diagnostic tests. Like, for example, I don't go get a mammogram based on how tight my bra is or how it may affect me getting breast cancer. And I'm just wondering, why is it that way for lung cancer? And what are you doing to have conversations with the policymakers to change that? And if you're not doing anything, I would challenge you to begin to think about that. So next year, this time, you can share that information with us.
So the question is about lung cancer screening.
Yeah.
Okay. First of all, Artie is the expert here on this. Not to push it on you, Cody, but I will say first and foremost, we actually are have really national leaders in developing lung cancer screening. Some of the faculty that are members of the Tisch Cancer Institute actually developed low-dose CT screening initially earlier in their careers and are continuing to do that. It is something that is one of the things and Cardi can speak to this better than I can, we want to actually develop mobile lung cancer screening so we can go to the communities and do this. It's something we've been trying to do for several years now, and we're trying to figure out how to do it, to be honest with you. But overall, I can also tell you, we've been pushing for policy changes that reduce smoking, right? And smoking, as we know, is a very important risk factor as a matter of fact, we have efforts that we're trying to push through to ban, and I think that they're progressing, ban menthol cigarettes so that they're no longer available because they're so addictive and create so many health issues. But on the actual screening side, we do have screening available in multiple sites in the New York City area, some of them in our minority communities, and but we have to push policy changes to increase the availability of this screening, and it's something that we're actively doing. Cardi is more up to date on this, I think, than I am. So, Cardi.
Challenge accepted. So I have lots of thoughts on this topic, and I guess I would challenge those in the audience to tell me, what color is for Breast Cancer Awareness Month that's coming up? What color is, what color is it for lung?
White.
Okay. So many more of you said pink though than you said white, right? Okay. Yes. So, when you think about lung cancer, I think it's often one of the stigmatized cancers because we think people did it to themselves, right? And there's actually studies done when you look at the amount of funding that goes towards certain cancer types. The cancer types that actually aren't as prevalent as you would think, or aren't don't have as high of a cause of death, are way more funded than those cancers that have higher causes of death. And I think it's a problem. It's in how we view things. But from a public health point of view, the reality is that 75% of all lung cancers are related to smoking. And so the reason why lung cancer screening came about specifically for those who smoke is because the way you hit the most of the population is you target what most of the population is at risk for. And it really has only been in the last, 15 or so years where we started to see a rise in the number of lung cancer cases among those who were never smokers. And that's because we've gotten more sophisticated in the testing that we can do to figure out what's really causing that. And so I think Dr. Parsons-Ramon hit it right on the head, and that the investigators here who are doing that work and leading that charge, they are trying to change policy and really trying to open it up and figure out who are those people what are those other factors that go into putting you at risk, so that that we can create a strategy where, quite frankly, it could bankrupt our system if we are scanning everyone over the age of 50 with like a CAT scan, right? And how do we sort of prioritize who those folks are? Or how do we create a system where we don't bankrupt a system by getting access to everyone for the care that they need, because we somehow find mammograms for everyone over age 40, right? Which is really the better way to look at it. And then I think we have time for one question from the Zoom.
So we have a question from Sarah. So what are some of the way that you have used to communicate the results back to the community? Like town hall, podcast, or newsletters? And what have you found to be most helpful and what has been less helpful?
I'm sorry, you broke up on me. Could you repeat that, please?
Just repeat it.
Repeat that was. Okay, so what?
Turn it off.
Okay, so what are some of the ways that you have used to communicate the result back to the community? And what have you found to be the most helpful and what has been the less helpful?
So who would like to take that question?
I mean, I'll take it, but I'd love others to chime in on this because it's. Kristen,
So I can speak to that. Absolutely. So there have been so many different ways that various projects have given disseminated information back to communities and communicate. Town halls have been effective. Podcasts have been really effective. I'm actually thinking about creating a podcast for a project right now that we're talking about why is it important for people to participate in research and have them understand what that means. Newsletters. So right now, the most effective ways have been through social media and having conversations, whether it's something on Zoom, whether it's something in person, but those personal connections and discussions and social media have been tremendously helpful in the last 3 to 4 years about disseminating information and communicating what the research results have been. That's been very helpful. And some of these, and going to community meetings. So I do that on a regular basis. I know Zarina does and others, where you go to community already organizations that are meeting and have monthly meetings where you disseminate information about projects and what's going on and provide updates. And that's really helpful as well. Because as Zarina mentioned, we're not thinking about dissemination just from one touch point towards the end of a project. We're thinking about it throughout the lifespan of the project. And what does that mean?
And just, I think all those points are really important too, even early on in projects when you're initially communicating, the premise of a project, the methodologies, and we work with investigators or researchers coming to really think about the language they're using, what their slides have on them. Are they really thinking about how this might be perceived across an audience that have differing levels of familiarity with research? So I think it's important through the cycle of communication.
So I just want to say one thing or ask one question. Basically, one of the things I think it's because we're running out short of time, maybe I'll just make a statement. And then if anybody wants to comment, is one of the ways we also want to engage with the community for research is through our high school students that are from the community and our college students that are from the community. And we really want to make this a vibrant, healthy environment for bringing them into our MD programs or master's programs or PhD programs so that they can be scientists that are, that actually are getting independent funding, their faculty, their PIs. And we think that that's something that is, unfortunately, not enough of that has happened. We need to do more of that. And it really is a high priority. We have programs to help fund students from the community for summer internships and that kind of thing. And that provides networking opportunities to help them gain admission. And so we don't have really enough time to go into the details around it, but something I just want to build awareness around, because some of our citizen scientists should also be young people, right, who then develop their careers here. And I just want to make that comment.
Okay, we can't take any more questions or comments at this time. Of course, again, we realize that we could spend more time on this, but let's stop and thank the first set of panelists today.
We're going to take a break now, but thank you for this important discussion to our panelists and our moderator. We're going to take a break until 12. We do have some lunches for those of you who are here. And for those of you on Zoom, we'll take a break and we'll come back at 12.
So much engagement. Yes, ma'am. We don't bankrupt the system. Yeah. Especially for New York. Go to the World Trade Center. There's lots of money there. And I believe that's true. I strongly believe that's where our final chance can be.
Have you ever been in touch with them?
I spoke to them. The next thing is I'm gonna speak with some researchers who've done some studies for, environmental studies, and then I'll kind of map out what's next.
Oh, sorry. You want, let us know.
Yeah. If I go here, we find where we were trying to share.
Right, like you leave down when you heard open from the. Do what is necessary.
Yeah. I'm thankful for the day on my end here. Went to the ER. And for the surgery that I had before then.
right, hope everyone's enjoying the break and their refreshments. I think we're gonna get started with the afternoon portion. I'm going to introduce Michaela Brown, who's our lead health educator, to introduce our speakers for the next section.
Thank you. All right. Hi, everyone. I hope you're having a great lunch. You're staying dry and warm. If you're on our virtual side, in person, I know we're dry and warm. So joining me today, actually, like Dr. Snow mentioned, my name is Michaela Brown. I'm the lead health educator here at Sinai. Basically, what that means is that I help oversee our other team of health educators who provide culturally and linguistically targeted health education throughout the 5 boroughs, sometimes even a little bit higher, Yonkers, Mount Vernon area. And so with this initiative, with this team, what we try to do is bring health education in the various cultures and languages. So I focus in the Black and African-American community, and I have my health educator, Natalie, who also joins me in that community. We also speak with the African immigrant communities, Latinx or Latina communities, Chinese speaking, Russian speaking, and we're continuing to grow and grow each year. So today, the first panel, thank you, that I'll be presenting is our linking with our faith-based initiatives to our faith-based organizations. And so we did have some changes to this slide. So originally, Miss Yolanda Kelly, who's the first or former First Lady of Kelly Kojic Temple, is unavailable to join us today because of a family circumstance. So do keep her in your mind. But we do have some other of our wonderful collaborators joining us on the virtual platform. So Miss Teresa Parnell, she is the treasurer of Friends Who Think Pink, which is a breast cancer awareness organization where she dedicates herself to fortifying the organization's financial stability, especially with this group, her unwavering vision for enhancing breast cancer awareness. She's able to collaborate with multiple organizations, especially in the Staten Island borough. And then Reverend Dr. Charles Butler, who has over 20 years experience as a certified housing, urban development, housing counselor, and program director for home ownership programs with the Harlem Congregations for Community Improvement, so HCCI, and he's a member of the New York Mortgage Coalition. And so during this time, he's assisted over 3,500 low and moderate income individuals and families becoming first-time home owners. All right, so if you can, just back to the first one, thank you. So we can hold them up.
They are out there. I just have to stop sharing.
Okay, perfect. Thank you, Patrick. Thank you.
You want, oh, that's it?
Yeah. Great. All right. So everyone can see you now. Thank you so much, Mrs. Parnell and Mr. Butler, Reverend Dr. Butler, for joining us today. So I'll take a seat.
All right. Thank you.
Thank you. All right. So for our first question, I'm actually going to pose it to both of you since you're on the call already. Is, sometimes institutions will reach out to a community organization with the belief that they know what the community needs, when in reality, we may have the resources, but we don't actually know what is needed. What should large institutions like ours be doing to best learn about the needs of your community? How can we best collaborate with faith-based organizations to meet needs? And so I'm going to ask Reverend Butler to first address this.
All right, great. Thank you again, Ms. Brown, and thank you for inviting me to be part of this distinguished panel and this wonderful discussion we have. It's very important that there is collaboration and understanding of both the needs of the community and the goals of both the community and the organizations, the institution. And what we've been able to successfully do with Mount Sinai is to create, and this was mentioned earlier in the conference as well, personal relationships that we now have with several members of the institution that we can share information with and come to having common goals and common ground. What is essential for our community residents and how the Mount Sinai can go about addressing those issues becomes paramount. A lot of things that you guys have in place, and it's just about really knowing how they're going to be implemented and what's needed. For example, the prostrate or mobile van. Prostate cancer runs extremely high in our community. And just by having the resources to have that van available And by having personal connections with individuals from the Mount Sinai team, we were able to successfully have the mobile van at several locations, several member churches. One of the things that's not in my bio, I am pastor of a church in Harlem. And so we've had the mobile van there on occasions. And it becomes essential because a lot of times people don't know where to go for help and what to do, how to find assistance. And they're going to look for the community leaders to help them direct them to the main source or the place to go. And so by having those relationships becomes central because you have a service and it's like, how do we get to the service? How do we get it in there? And the trusted person in the community will be the one who will be able to link the two together. The COVID vaccination, another, a big issue. There was a lot of hesitancy, reluctancy around that. And by addressing it as a health educator and a community leader, people would listen, understand, and be less apprehensive to do so. So we come together, we meet, we discuss plans, common goals, things that are essential for benefit for our community and how you can do it. But it has to be on a personal level. There has to be the trust factor involved, and that comes from over time in developing a strong personal relationship.
Thank you so much for your answer. Now I'm going to pass it over to Ms. Parnell. Oh, you're still on mute.
You're still muted.
Yes, all right. Hi. First, I want to say I have had the honor of hearing Reverend Butler preach. I just wanted to share that because I've been at his church. To piggyback on what you've said, we just started reaching out to the community after the pandemic, and we find being within the community and having health fairs and reaching the community where they are is where we're trying to utilize what Mount Sinai has for the community in Staten Island. Staten Island doesn't have, they're just now really getting started with creating health fairs and programs to allow for the community to see what out there is offered. A lot of them don't know about what Mount Sinai offers and getting the education out there. So we've been creating fairs, health fairs in the parks. We're doing one in October and we just did one in June. So we're trying to really make it accessible and easy for them to get the information, as well as promoting it on social media. Social media seems to be the new way of communicating and the new way of reaching out to the community. And we're just trying to make it create that trust relationship, with the community. As we all have said, it's very important for them to trust us. So I feel the more we communicate with them, the more we offer them, the more people will come out and see what's going on.
Thank you both. And both of you have mentioned that part of the initiative to get connected with these communities is to meet with the right people. So
Yes.
what would you say, how would you propose that institutions like ours do that? What type of congregant or minister do we need to be reaching out to? And what ways are the best ways to get in touch with them?
The visibility, I think, is key. I've had several of the Mount Sinai staff come and speak at our General Assembly meetings. Harlem Congregation has over 90 houses of worship in our membership network. And so when you, a member from Mount Sinai, come and able to make a presentation at one of our General Assembly meetings or our community improvement group, which is a group of block associations and community leaders that come together, that gives you and them access to you, because now they can put a name, a title, a phone number with that individual and with that institution. It's very discouraging for me when I say make a phone call and I'm getting hit with a voicemail or, you know, press 1 for this, press 2,
Right,
and never really getting a person,
right.
you know. And they'll even say, if you need to speak to the operator, press 0, and you still get a recorded
Yes.
message. And so when I can say, oh, let me pick up the phone and call Dr. So-and-so or Reverend Dr. So, you know, and have that connection there and get right through. And that's what they like. So again, by being there in the grassroots, you look again at Jesus. Jesus was with the people. He was there. He's meeting with them. He's eating with them. He's sharing time. And that becomes valuable in making that connection, because then I'm not dealing with an impersonal institution, but now I know people, key people on the inside that can, if they can't help me, they can at least direct me to the appropriate person. And that's how we work.
Yes, that's correct. I definitely agree with that. Being new to Staten Island, I've been here 10 years. I'm still learning the place myself, but I do agree that being part of the community assembly meetings as well as the church-based meetings is the best effective way, as well as there are a lot of nonprofit organizations on Staten Island trying to reach the community for several different things. It would be great to have you become a part of it. I try and share your information with everyone that I come in contact with to make sure that they know that this is available and that you guys are willing to come out. You know, sometimes they feel like Staten Island is the forgotten borough, but it's that you're not demanding the need. You know, we're starting to demand the need, like we need the information provided for our area. So we're trying to make it as accessible and possible for the members and the community.
Thank you both for sharing that. And so I know that our organization has worked with both of you, and I see in the chat that Reverend Dr. Zarina Costello is sharing how she has worked with HCCI in the past. But what would you say are the types of services and programs and workshops that the community really needs and that we can provide? And also, how do we continue to keep engagement in these workshops and services?
Well, I think from what I have seen, every single Zoom that I have been part of or affiliated with is needed. You know, Staten Island seems to be the smallest borough, but the highest rate of cancer. So I think they're just not realizing that there's assistance. So it's hard because just like any borough, any neighborhood, there's a little bit of a divide. So what I've been trying to do now is break up some of that divide and get involved with everyone. Like we're a cancer-based organization, but we're now getting in touch with the bikers, the distinguished gentlemen. They work with the kids, but it's the parents that I need to speak to. We're working with community-based organizations that teach. We gave out school supplies that teach chess, that work with Juneteenth or Kwanzaa or Black History Month. We've been trying to get involved in everything that's happening in our community so that we can bring the health aspect of it, you know, adding the need for encouraging to get your mammograms, to have your prostate screenings, to know if you need a lung cancer screening. You know, we've been like trying to tap into everything that's going on, just so that we can reach the people, because we have to find them where they are. They don't always necessarily come to us, and we know that they need to have a trust and a relationship with us. So I feel like the more they see us, the more that willing they'll be to join and accept the information that you as Mount Sinai have provided us with. But that's what we've been doing.
Reverend Butler,
You're
you're on
mute.
mute.
My phone was ringing a minute ago. One of the things that we become aware of is the lack of screening that many members of our community fail to get. And so one of the things I do, again, with the assistance, great assistance from Mount Sinai, is to provide opportunities, where, as Sister Purnell was saying, go to the people. So our health fairs, our community days, which is a health fair where we provide screening. And a lot of times, even with the screening, we have to almost manipulate and motivate people to get the screening. Like if you get 5 screenings, you'll get a t-shirt or you'll get this or something like that, because they're still just very resistant. A lot of times they're afraid because, oh, they might find something wrong. And I'm saying, well, that's what hopefully they won't. But at least if they do, we can do the early detection, which can, help bring about a cure or a remedy. And that's what happened when we did the prostate screening in the park 2 years ago. Some of the people there were in early stages of prostate cancer, but the fact that it was caught early enough and detected, they were able to get cured. So by doing that, our health fairs, just constantly providing education. Education, a lot of times, is the key. Dr. Costello attended a workshop we did at Mount Calvary just a few nights ago on oral health. And we had only about 12, 13 people there, but the information was key, in terms of sharing and providing the information. A lot of times, still, people discount the level of education, and just by having that knowledge, the information can be key. So we continue to put it out there every opportunity we get.
And you both have mentioned like presentations, getting into the community through like health fairs, social media. Do you think that there are any topics or like cancer subjects that we're just not covering enough, that we need to be more proactive in reaching the community through education?
Almost any activity, we kind of will implement some education in it. It can be a gospel concert and we'll still have some education. There'll be flyers on the table, all the time, because it's like every opportunity we have, we understand. I mean, we talk about the Harlem community, the African American community, the community of color. Generally, our people are, I say, we finally get to be the best at something, and it's the best at being the worst. High maternal mortality rates, high cancer rate, lowest, death rate, high death rate, all of that. And so as much information as we can put in the community, you just hope some of it will stick. Somebody will hear something and say, hey, I better try that. I haven't been feeling well. This runs in my family. Maybe I ought to get checked out. And so, yeah, every opportunity, even doing my home buyer education workshops, we'll talk about health.
Right.
Because that's important.
What I do know is that from the statistics of the highest rates of cancer, you are covering them. They are mostly the reproductive areas, and those are the ones that you guys have at your forefront. So I think you're already utilizing the most important ones that are affecting our community. It's just getting the community to hear them. It's almost like we have to have whistles and bells to get them there, but we're doing it. We're doing it.
There is such a level of mistrust still in the community. Nobody wanted to get COVID shots. Nobody wanted to get the vaccine. No one wanted to get the booster. Going all the way back to the Tuskegee crisis, so people will still, in the back of their mind, they still have that. And for some people, there's just a fear of doctors. I remember I was doing job placement and job development at one time, and I had a job interview for a lady in a hospital. So I have a position for you. They're looking for someone with their skill. She said, I don't even like to walk by a hospital. She said, I'll cross the street. That was the innate fear of just hospitals. So it was like, don't expect me to work there. I'm not even passing. I don't want the shadow of the hospital to touch me.
Yeah, it is true. The community, Black and Brown community, we do have a fear. We will first self-medicate before we go to the doctor. You know, we a cure all in all, you know, drink some ginger ale, rub some Vicks on everything, and they think that's gonna cure, you know, old school remedies, and not
Yeah.
realizing that, you know, uh yeah, there were some horrible things that happened in our history, but times have changed, and us as advocates, we're advocating for you to get fair, proper, affordable resources in case you are sick. You know, that's why we do what we do, is so that we are available to prove to you that there is a legitimate doctor and program and research and treatment and cure for cancer out there, that they are not treating you as if you are a guinea pig. And it is hard because education plays a big part in it. And if you don't know, how do we get you to understand? So we also have to talk their language, you know, which is also another barrier, because some if you're not dressed a certain way, or you don't talk like me, I'm not going to, you don't understand me and I don't understand you. And that's also becomes a problem, you know, because people are intimidated and fear plays a big part in it. And especially with people lie. I know people who have had cancer and have lied and never sought treatment until it was too late.
Mhm.
You know, those are the
Thank you so-
things we want to prevent.
Absolutely. And so you've both mentioned like this fear of doctors, like one thing we call the white coat syndrome, or of like, you know, we see
Yes.
the doctors approaching, we don't really want to talk with them. So I guess who do you think is best to go into these communities to bring this education, to work closely with our gatekeepers and our community organizations?
Oh, no, I still think doctors need to go. I'm not, you know, saying they shouldn't, because you can't, I'm not qualified. You know, I feel that they just need to reach them where they are. Sometimes when you talk to doctors, and doctors do it all the time, they talk their language. You know, like if you say the word hypertension, the average young person doesn't know what that means. But if you say your blood pressure is high, then they understand what that means. But it's the same words, it's just said two different ways. So same thing with people, when I mentioned prostate, we were having a prostate van, we were going from barbershop to barbershop because they're the ones who don't even have healthcare. And we found that they had the assumption that they were going to actually have a physical exam. And I had to explain that, no, they're just going to draw some blood. And people were afraid. People were utterly afraid, you know, and I was surprised. I almost wanted to pull the van up to the barbershop and say, look, give out free haircuts for everybody that gets a, you know, gets a prostate screening. What I got to do to get them in this van, but, you know, because it is sad. You have to almost buy their, them to get them to do, to check themselves out, to
Right.
take care of themselves, you know.
Yeah, that's a big challenge. You know,
It
we've
is.
looked at peer-to-peer young people trying to do that. Like you have the community health workers or peer workers to try to go out there, train them and trusted individuals in the community. It's really difficult. It's really the conversations itself. People would rather talk about sports or something other than their health. And as important as that is like really neglected, you know, on so many different levels. And we just have to continue hammering and driving that point home every opportunity we get. And as again, Sister Purnell is saying, the barbershops, the beauty salon, the clubs, or the places where where people can sit down and talk. And where are they? Where are the people that we need our target? Know where the target is And then you have to have, I hate to say bait, but you have to have the correct bait to attract them, because otherwise they're like, I don't want to hear it. I don't want to hear it. But if you can say that whatever the phrase, the buzzword or something. I know brothers who died at young ages from prostate cancer and colon cancer because they wouldn't get checked out. And it's was not necessary, but they just refuse. I'm not going to have anybody touch me.
Right. No.
And it's horrible, And so it really comes down to education. And like you said, showing them it's just drawing blood. It's not,
Right.
That can make a big difference. And we talk about the difference. And sometimes brothers who say have been tested and were found in stage 1 because they got tested early, they are really good spokesmen, because they can say, I was in that boat. I didn't go. And, when I finally did go, they did find cancer. But since it was early stage, was in detection, they were able to get the proper treatment and overcome the challenge.
What I do like here is with Mount Sinai, you guys have the objective. You offer the information, the facts, all of the logistics of what it is you're offering. But then you turn around and you make it very subjective. You bring in the emotional panel of it. You grab at the heartstrings of the community when you do your Zooms. You utilize a person who actually has experienced some form of the cancer that we are actually Zooming at that time. And that helps too, because what happens is, while you're giving them the facts, you're also giving them the emotional aspects. And by doing that, it becomes a ripple effect. So people may not remember all of the logistics of it, but they remember the story. So they'll go and tell a friend and tell another friend about the story. So that allows for us, as we organize these, we remind the people who were at the previous events, look, we're doing it again. And they remember how they felt, what they learned, and then they turn around and share that. That's what I appreciate about this organization, is that you're not just spilling the facts. You're also utilizing previous cancer patients by telling their story. And that makes a huge impact. I'm never happy with the numbers. If 100 people show up, I need 200. I'm always wanting more. So I won't be happy until everybody hears at least a glimpse of what is out there and what is there to offer, because you guys offer a lot. And if all we can do is constantly be the foot soldiers and constantly get it out there. So, that's what my organization is doing. Even though our name is breast cancer, we have adopted to fight for all cancers.
Okay. Thank you so much for sharing that, Mrs. Parnell and Reverend Butler. And so one of our panelists unfortunately was unable to make it today. She did come down with COVID, so she's recovering from that. But she was able to provide us with her answer to one question we had, which was, how does access to healthcare and cancer care affect your organization's community? And how can institutions like Mount Sinai address this issue? So Ms. Sanaya, she shared that access to healthcare and cancer care has a significant impact on many Muslim communities, especially among immigrant and low-income families. Mount Sinai has been doing an amazing job hosting workshops and programs aimed at increasing educational awareness about cancer prevention. Extending these valuable initiatives to Muslim community centers and other faith-based organizations can significantly enhance educational outreach. By providing resources and actively supporting workshops and screening camps in and around our places of worship, Mount Sinai can empower our community with the knowledge necessary to make informed healthcare decisions. This is especially crucial for those who may not be aware of the resources available to them. So like you've been sharing, Ms. Parnell and Reverend Butler, we need to be in the community. We need to be active participants and not, going in for one program and like never hearing from us again. But consistency and relationship and trust is key. And so I do see some of the questions coming in through the chat. So I will open it up now.
Yes, Christy Hill.
Christy Hill.
Hi, can you hear me?
Yeah.
Yes, we can.
Hi, my name is Christy. Let me turn on my camera. Hope you guys can see me. My name is Christy. It's dark where I am. Sorry about that.
Okay.
I am a citizen scientist for the University of Florida, and I'm so glad for this topic, Reverend Butler and Miss Teresa, because I didn't know where to exactly ask the question that I have. So the question that I have is, my father is a cancer patient. He has chronic lymphocyte leukemia, and he also has prostate issues as well. And I was in the function last night having a conversation with some people in a prison ministry setting that were telling their stories. And they asked me what I do. And I was like, I'm a citizen scientist. I also work for cancer research. I'm a patient advocate for IBD. And so we got on this topic about research and having cures for cancer. And one of the people at the table asked me, how close do you think, will there ever be a cure for cancer? And because of what I do, I honestly feel like the doctors, the scientists, the researchers want to have a cure for cancer. And so my father, who is a pastor, Mr. Butler, Reverend Butler, that's why I want to ask you, he seems to feel as a pastor, as a person with cancer, that there will never be a cure for cancer because the doctors and the pharmaceutical companies are working together. And it's a money-making business. And I completely disagree, but that's his perspective as a person that has cancer, that's currently on chemotherapy. What is an answer that I can help someone like him? Because he is a member of the community, he's a pastor, he is a retired military chaplain. How can I give him an answer that will help ease his mind that there are people out here who are trying to, have cures for cancer, so he can be able to then reach the community with his role? Because right now he doesn't feel very secure that people are trying to have cures for cancer. So that was my question. And thank you for your talk. I loved all of this.
I think he's wrong. I think there is a cure. As I said, I've known people who have been cured. The key is early diagnosis. If you're stage 1, it seems like it can be, with the treatment, be cured. Now, if you're already down in the stage 4, then it's probably too late, and there's nothing yet for that. It's like I do foreclosure prevention. If I have someone who's only 1 or 2 months delinquent, I can pretty much get them out of foreclosure. But if they're a year and a half behind in their mortgage payments, it's a lot more difficult, and more than likely it's not going to happen. So the first thing, again, goes into screening, always screening, early detection. The better your chances are of survival. And Sister Thomas Travis, who was on one of the earlier panel, she talks about having cancer, I think, diagnosed 2 or 3 times, but was able to receive treatment and cure. Now, it may keep comes back, but it can be cured. The people who generally are not curable are just too far gone. But again, in the mindset of the community, to address the other point, pharmaceuticals and doctors in the community, they think that they're working together, pushing drugs, pushing that, not trying to come up with a cure. And that's, again, the mindset through education we have to constantly address and try to show where they are. And as I said, I can bring people in on a panel that can say, I'm a 10-year, I'm a 15-year, I'm a 25-year cancer survivor. There was a lady in our church celebrating her 78th birthday, and she had cancer about 15 years ago. She said, I'm a survivor. My associate minister, he said, I'm a 27-year cancer survivor. Another lady, I'm a 32-year cancer survivor. So, sometimes seeing examples, real live examples, and hearing those stories. And a lot of cases, when you hear you have cancer, immediately you think it's fatal. Does not have to be.
Thank you for sharing that, Reverend Butler. I think that brings up a great point about not only educating our community members, but also educating our community gatekeepers. Because if they don't believe our message, they're not going to share that message with their congregations. So thank you so much.
Yeah,
I
somebody
see
put in
another.
the chat box that even with stage 4, you're not too far gone. So it's stage 4. I just saw that, like glancing in the chat box. I saw that. So yeah.
Yeah, even here, you are learning more and being able to bring this information back to your community. Great. I see some other hands in the Zoom, but also if you have any hands in the room, feel free to raise them as well. I'm going to turn to Luis.
Yeah, hi. I myself am a cancer survivor. I still have not hit my 5th year, but I do go frequently to get a screen to see what my numbers are like. But with me, I didn't initially get screened. My initial screening happened by accident because the lab did an additional test, which was the best mistake that anybody can get. I have to say that the work that Mount Sinai is doing is very, very good. And it's changed many lives. But I live in Upper New York, and in rural areas, the minority community are at an astronomical risk. Um, we suffer all the same things that have been said for the 5 boroughs, but there is also not enough physicians, not enough areas to go, not enough information. I think the mobile van has been a very unique wake-up call as it's come up to my area on numerous occasions. But the more and more it looks like we may need a replica or 3 of the mobile unit, because the amount of work that needs to get done is too great of a span in this state, New York State, and I can't talk for other states, but there's just not enough for us to be around and be able to cover this catchment. And I think that there are a lot of folks that are do, because of lack of education, do not understand the early screening and the advancement in care. But there's also areas that have complete, utterly no service in healthcare. So I really thank you, Mr. Charles Butler, for everything that you said is spot on. And I encourage that for everybody in the panel to also look into your state senators in Albany, because it should be more robust funding to get these programs to also expand.
Good seeing you, Louis. We met at the Mount Sinai award dinner last year. Yeah.
Bringing community everywhere. All right, I see another question from Ms. Brenda Balone.
Hi, I just wanted to comment on Christy talking about her dad. I'm Linda Balone. I work at Queens Hospital Center in the public hospital system on cancer clinical trials. And I work at both Queens and Elmhurst, and I was involved in cancer trials, COVID trials. So I know how people feel about research and clinical trials and drug development. And I agree with Charles and Teresa that, there are a lot of cures with early detection, but but every patient, in my opinion, I work with clinical trials, they're at a different point. I look at all my patients as like a Christmas present ready to be opened. So I agree with your dad that he should be a discriminating consumer of his care. And instead of just shutting the door and thinking about it in a way that all the doctors are in cahoots with the pharmaceutical company, talk to them and ask them, tell them that that's your fear. I know with clinical trials, there's a part in the consent form that's a regulatory requirement that we have to disclose our financial conflicts of interest. And that's a good thing maybe to tell people. I do work in the community on talking about clinical trials. And you're right, a lot of people feel the way your dad feels. But if they know their rights and their right to know that and their right to ask about it, it might empower him instead of just saying, trust me, they're not. Just say, hey, we're not allowed to do that. We have to disclose this to you, especially in a research study. So, knowing your rights and asking about them is really important.
Thank you so much for sharing that, Ms. Ballon. All right, is there any questions in the room? Yes.
My name is Francis Caron. I'm the program coordinator for the Bronx County Cancer Services Program. I have a question for Reverend Charles. I've been working in the public health industry for a number of years, let's say since 2007. What I don't see among congregations is, maybe some do have and some don't, but most of them that have worked with, they don't have a health ministry. They have many ministries, family ministries, youth ministry, and so forth and so on. But we talked about bringing education to the community, but the community, I would say 60% of a community attend congregations, one way or another. What if we develop a health ministry within congregations where you could educate the congregants who are constituents of the community? Would that be something feasible, possible? Do you believe that is something that could work? Because I know we do health fairs, maybe once or twice a year or here and there, but having a health ministry with the congregation would be more suitable to really educate on all sort of health levels. You could invite professionals that would talk about anything. We don't expect congregations, congregants to be knowledgeable of health, but some of them do. They could volunteer and do that as well. But at least the community, the people that are attending, right, will be more trustworthy of being in their skin rather than being out there, right? And to comment on what the lady from Florida and her father, people who are diagnosed with cancer today are having better treatments than those who were diagnosed, let's say, 30 years ago. So research is important, and not only looking for cure, also better the outcome of survivorship. So she can remind her father that it's a genetic issue. It may not be possible to find a stopping pill, but we do have the best right now, at this point right now, we do have the best treatment for those who are receive early diagnosis, and even those who are in somehow later stages. So yes, research is important. And as much as we're doing research, we're looking forward to improve treatment, recoveries, and survivorship.
Thank you so much for that question. Reverend Butler, I'm going to turn it back to you as our last question about having health ministers in the church. And then we will continue this momentum with our next panel.
Okay, great. Yeah. I just see that Dr. Costello had put in the chat box that great point. We help communities create health ministries. Project Hill is part of the community health advisory program. And Project Hill helped me create a health ministry at Mount Calvary. And we just started doing initially some health ministry and then health activities to change. You know, we had a walking ministry for a while during the summer where people would come together every Saturday and we would just walk 2 blocks, not 2 blocks, 2 miles and back. And so, you know, started to get people to do that. When we would do the food distribution, we would do hypertension testing and HIV testing. So we started implementing normally the health activity with another activity. People was going to come for food. We said, you're not going to get any food until we test your, do a blood pressure screening. And so you kind of can implement things along that line. If you have anyone in your congregation who is working in the health profession, those are the kind of people you want to kind of help engage you to get the program up and running. But anyone, as we did that, then others came in, like I said, the members of the congregation who were cancer survivors, they wanted to join in. Some other people wanted to join in. So we were able to get a number of people in and to encourage them to do the activities. So, you know, even at one point, what we were doing with our meals, removing the sugary drinks that we normally would share with a meal and put water on the table. And at first people were like, what are you guys doing? Where's our iced tea? And you know, we explained to them we're drinking water. And eventually habits, you know, new habits started to form. And just talking about walking, you know, rather than taking the train once a stop or whatever, walking when you can, walking and getting physical activity. And it's something you have to keep working at. You know, at one point we had maybe 25 people in our health ministry actively engaged and involved. My wife started a fitness class where Saturday mornings, the women and some men would come together and do a fitness program, you know, exercise aerobics. And so, and she made it so it could be chair aerobics for those who couldn't stand. But, you know, again, you try stuff and see what works. And if it doesn't work, you know, refined it and come back and try something else. But you just continue to push it. And so we do a monthly program of some sort. And then we highlight it with our annual health fair. We have our street fair, you know, things like that we constantly do. And eventually people will start to join in and accept it. And the other part of it, as we said before, you have to still put some kind of manipulation. You're getting a free something or the other. Human nature wants free. That's just human nature. Oh, it's free. I'll get in line. I don't even know what they're giving, but if they're giving it something away, I want it.
Thank you so much, Reverend Butler and Ms. Parnell, for being on this panel, sharing your thoughts. If we could give them a round of applause.
All right, thank you.
Great. So now we're going to continue this momentum. I see there's great discussion happening in the chat. But now we're going to go over to our community-based organizations, and I will be joined by Ms. Anna Bartolome.
Hello, good morning.
Tiana Welch. Good morning. Tiana? Family. Link should be up. All right, so I don't see Ling on the call right now, but we're going to continue with Anna and Tiana, who's here in person next to me. So just as brief bio, so Miss Anna Bartolome, she started her professional career as a bilingual educator working with immigrant families in inner city schools for 13 years. After going back to school and pivoting her career to work in the nonprofit sector, she's now the operations manager and community outreach coordinator at the Brooklyn College Cancer Center. She has worked at BCC Cure for the last 3 years, where she has a central role in administration, supporting its goals of facilitating cancer research and supporting college students in their path towards the biomedical and public health fields. And on my left is Ms. Tiana Welch. So Tiana is currently serving as FIPS Neighborhood's Public Health Director, providing leadership in health and social service resource navigation. In her current role, Ms. Welch manages the overall strategic planning, program operation, and data analysis. Additionally, she prioritizes community asset mapping, external partner relationships, and community health worker engagement. So thank you both for being on today. All right, so getting started, with our faith-based organizations, like we heard before, a lot of the outreach we can do is through our health ministry, through our pastors, through our communities. But I guess, Anna, what has your relationship been with Mount Sinai, and what value has our partnership brought to you and your organization's mission?
Thank you first for inviting me to be in this panel. I'm very excited to be here. We have collaborated with Mount Sinai Tisch Cancer Center in a way that has brought both community outreach and then an education component to our here's someone else, to our partnership, our goal in working with against the fight of cancer in the Brooklyn community. We do programs with Tisch through sorry, I'm a little nervous. We work with the center in having the health educators come into the community, and we as a university, Brooklyn College, are a trusted member of the community, and we partner with organizations that have community members from the Hispanic, the Latinx community, but also the Caribbean and Haitian communities. And we have been able to do multiple workshops thanks to the fact that we have health educators from your organization, and we bring them into the community and we teach in that language. You teach them in that language. And then we also have a really amazing program with you that you have developed for our students called the Lay Health Navigation Program. And you train our students and they become lay health navigators. And so these are students that speak different languages that are the community's languages, and they're able to do navigation and get some of the patients that you may meet in the fairs that you hold and we hold, and get them all the way to screening thanks to that navigation. So these are some of the things that we do, and we are so thankful to be able to partner with you to be able to do this.
We're happy to partner with you. And in partnering with you, have you noticed any changes with your students or in the resources they try to seek out, or even with the community organizations you work with?
Yes, well, amongst the students that have been part of the 2 cohorts that we have had already, there's definitely a lot of positive feedback. They have really embraced being part of the health community and being able to continue their education either in public health or in different fields, but within health, because they have really felt that this program has allowed them to gain some experience that has solidified their desire to work in the health field. And then in our, I think you asked, what was the second part you asked?
With the community organizations.
Oh, well, I mean, they keep calling us and asking for more events. So one of the things that we do is we do every semester, we contact organizations and we create fairs, or we help them have workshops. And so they, it is a recurring ask that we get. And it seems like everybody is very happy, and the participation is very well received. The participants receive very well the sessions and appreciate having somebody from Mount Sinai speaking in their language. And also hopefully part of what we do is we bring a van that has a service, so either mammograms or prostate cancer screenings. And so, of course, they're grateful for that as well.
Thank you so much for sharing that. And Tiana, I'm going to ask you something similar in terms of how does access to healthcare and like cancer care affect your organization's community? Like, how can our institution, like Mount Sinai or other institutions, address these issues?
Okay, good afternoon. In the communities that we work with in FIPS, they tend to be historically underserved communities. And in that, you see that they face health inequities, and there are poor health outcomes overall. And in terms of access to care, healthcare and cancer care, there are practical barriers that we notice as we're in the community. So this can be something as simple as transportation, childcare. These are things that maybe, from the research level, you may not consider as barriers to access to care, but they are present and they are affecting the community and their ability to access those resources. Additionally, there are information gaps. The information is not reaching the community. People are, we've spoke about this throughout the panel today. There's a lot of mistrust in the government. There's a lot of mistrust in medical institutions. And with that, you need trusted messengers. And that's why we have community-based organizations and faith-based organizations represented here, because there is such an importance in having trusted messengers deliver that information, share that information with community members. So just a little bit about what that can look like. FIPS Neighborhoods has had community health workers in the field since the 2021 with COVID and wanting to, see an uptick in vaccines. And, that speaks to, and the work that the team has done really speaks to the power of a trusted messenger. We are a team that look like our community. We speak the language that our community speaks, and therefore we are considered people that they can come to. And that's really important in doing the work and spreading the information in bridging those gaps in access to care.
Thank you so much for sharing that. And then I see that Ms. Ling too is also able to get on the call. She is the program coordinator at Project Signs Hamilton Center, Hamilton Older Adult Center, and she has worked in the not-for-profit field for several years, engaging the community and vulnerable populations. And so similar to what I asked Tiana, Ling, how did you get connected with our program, and what made you interested in partnering with us and seeking the services for your communities?
Hi, so when I first started the position, I was told by my supervisor that we had like a long-standing partnership with Mount Sinai's Cancer Institute. So she forwarded me your information, and I reached out. And I thought it was super important for our population because it is older adults and aging. A lot of people have been diagnosed with cancer or are concerned about it. And I thought these programs would be really important for screening and getting information on how to move forward. Additionally, your program offered like different types of cancer. So we were able to do a cancer education series for the older adults, and it was also multilingual, which benefited most like other populations, not just English speaking, which works with our Project Find mission to work with low to moderate income individuals. And from there, I also referred your programming to our other centers because they were also like looking for education for their members as well.
And thank you so much for sharing that. I just want to pose this question to all the panelists. So you all work in different communities with different populations, but what do you think is the biggest limitation to engaging in this work or to bringing this message to the community? And I'll start with you, Ling, since you're unmuted still.
I think the hardest thing is that cancer is still like such a big taboo word, and also no one really wants to talk about like illness and disease, even though it's something very real and like it's something that we need to be aware of and being screened and checked for. So that's definitely one of the limitations, like the the stigma and things attached to it. So
Anna?
Adding on to what Ling said, I think that just and maybe because of what she said, getting them in the room to be able to then give the information is a challenge. And so I think that because as part of Brooklyn College, we have so many young students who are eager to help and be part of our office. We have been utilizing their amazing ability to do social media and trying to utilize this new tool of very TikToks and doing Facebook Lives and things like that has really become something that is a totally different way to approach reaching the people who need to hear the message. And I was very excited to hear a panelist in a prior session mention that they were going to be doing a podcast. And I thought that was an interesting approach as well. And I think that in terms of barriers, we have so much information to give and we want to give the resources, but having them be in there to listen, sometimes that is why we need to really be able to partner with organizations that are really close to the community. And so yeah, that's my take.
Diana.
Yes. So when we're talking about stigma, as Ling mentioned, and about meeting people where they are at, as Anna mentioned, consistency is very important. So in order to reach your community, you need to be a consistent face, a consistent presence in your community. So whether that's through educational sessions, when you're doing that weekly, monthly, bringing these health topics to community members about cancer, about preventative measures, these are all important things. And as a panelist mentioned earlier as well, around disseminating results, you want that relationship to be comprehensive, right? So even after studies are completed, and we want to make sure that we are coming back to the community with that information.
Oh, all right. And so what other like patterns in your community do you recognize that our programs would benefit from engaging with? And so like Anna, you were mentioning like you have a bunch of course, college students, and so that they know that they can get on TikTok or Twitter or Instagram and they can engage with the community that way. Are there certain avenues that we should be exploring with each community that you all work with to help with engagement?
Well, we already do one that's key, which is make sure that the events are in the native language of the community that we're trying to target. That is very important. And I think that we need to make sure that there's, again, going back to trust, the person who's giving the talk needs to be a member that is trusted, but also it can't just be a trusted scientist or a doctor. It's not, the white coat is actually doing the opposite effect of trust. of wanting to bring trust. It is the member from the community. I think so bringing people, having the peer advocates or the students become advocates, become health educators from that same community that speak that language. And then also doing something as practical as doing events that are in the evening instead of during the day for work, to allow those who are working, doing events that are in the weekends, going to the location where they are already having different events, more social events, for example, or art gatherings, or cultural gatherings. Going to them, that is something that we need to ensure.
Yes. So a pattern that we've observed is that a lot of times community members don't feel certain issues are relevant to them. And I think that's where, as Anna mentioned, peer advocates come into play, because people are seeing people that look like them are in their community facing some of these similar health conditions. And as we want to promote that within the community. We want to promote that within organizations that are seen as trusted messengers, in order to get that information out there, and let them know that it is relevant to them, and it can be relevant to, maybe not to them, but maybe to their neighbor or somebody that they know, a family member. So that's one of the patterns that we've definitely observed in our community.
Thank you. And Ling, the question we were asking is, what patterns in the community do you recognize that our programs will benefit from? And so I know in working with the older adults population, what do you think we should be capitalizing on and how we can best reach that population?
I think one of those things is that, they are aware of like the screening, the doctors have already kind of told them to go and like do all these things, but maybe a focus on like, what happens after, right? Because it's like, they got screened already, they know, or some people are in remission and they're like worried about that. So I think a little bit more details on the after effects would be really beneficial for our older adults.
Thank you for sharing that. And you've all mentioned like working in the community in some capacity in terms of like having health educators or community health workers who look like and represent the community. How do you think what is the best way for institutions like ours to, find these members of the community, to like hire them and onboard them and like train them to get back to their own communities?
Yes, I can go first. Yeah, so partnering with organizations that are already in the community, that have deep roots in the community, is one approach to getting, connected with those community members that you are looking to target. And not only just wanting to connect, but an objective to empower those community members as well. Therefore, you have a relationship that is beneficial on both sides.
On our end, we already do this, but there are so many amazing students, college students that are part of the Brooklyn community, and they are bilingual and they're in search of opportunities. So of course, this is a wealth of opportunities for you to reach out to them, and this is part of what we do to partner, why we partner together. But at the same time, I think that making sure that you are those members of the community that may have already had cancer and they are survivors themselves, training them to become health educators and advocates for cancer care, I think could be is and I know this is done. I don't know, that's not part of what we do at our center, but I think that is so important, and it can really empower those patients who now are survivors, especially if they are in the minority groups that we're really trying to benefit. And if there's a payment attached to this, because then you're empowering them at a level that is also a professional level. and you're allowing them to make an earning.
And so what do you think is the best way to ensure that our partnership is mutually beneficial for each party? So as much as we're entering your community and your organizations to spread this message, how can we ensure that we are providing you with what you need and what the community members need? I'll pose this first to Ling.
I mean, I think you do a good job when you provide the resources and like, refer them to like your agency or other partnerships that you have. And that way it's mutually beneficial because they're getting that education, but they're also going to other community programs to get those screenings that they're following through. I think another thing could be, maybe having inviting members of the community, like kind of like this, where they have this talk, and not just have professionals, but have those community members be able to ask those questions there as well.
Can I go next? I think that one of the key things is to continuously go back to what our mission, what is our common denominator, like someone else had said earlier, and what what in our mission is the same, and what can we focus on, maybe on a yearly basis or on a bi-yearly basis. What is going to be within our combined mission? What is going to be our focus for that that amount of time? And so I think that will create a sort of clarity on how we can collaborate and yeah, come up with an idea for different activities that we're going to do together to make sure that we follow that impact that we're trying to make for that amount of time.
Having resources available is definitely a great approach to promote continuity of care past those educational sessions or past just giving out that information. Having resources available where they can get connected to providers that can answer the questions that they have, and also just remaining immersed in the community, because community needs to change. And unless you are there, unless you are on the ground, you will not understand really what the root and find the solution through that. So just being fully immersed in the community and continuing that so that you can be able to respond to the changing needs, and therefore, the relationship is beneficial on both sides.
Well, thank you all so much for answering these questions so far. I know that we're approaching the end of our time soon, so I'm going to open it up to any questions in the room, any questions on the chat. But if not, I have a couple questions.
I have a question.
Yes.
One of the areas of my cancer care that has been increasing.
One of the areas of my cancer care that has been increasingly important to me as a patient, and full disclosure, Dr. Smith is my oncologist, and these are conversations we've had, and sometimes she plays therapist, is my mental health care. And it's become increasingly difficult and challenging to get the care that I know I deserve. And some of the barriers are costs, and other times finding a mental health provider I can connect with that will even accept my insurance or any other insurance. And what I wanted to know, like, how is Mount Sinai assisting patients like me to make those connections? Because the clinical care is one thing, but the mental health care for me is really important.
Sorry. Hi, Colin. So as mentioned, I'm an oncology social worker. So we do have oncology social workers available to our patients here at Mount Sinai. And if patients are not patients at Mount Sinai, then we do refer out to our community partners and have resources like cancer care or other community partners that we can refer our patients to. And the services of our oncology social workers here, we don't bill insurance, and those services are provided free. Sure.
And we had a similar question in the chat about accessing mental health services through community organizations. And I just wanted to pose it to the panelists as well as like, have you seen this need in your communities that you're working with? Are people, after a presentation, are they coming up being like, yeah, this was great, but where's the mental health resources?
Absolutely. The resources are limited. They are lacking. However, at the level that we can make an impact, we do try to incorporate a lot of mental health activities. Sometimes we host it over at our office, sometimes we host it over at the senior center, just as an opportunity for people to take a mental break, provide them information as well as things that they can do on their own, and connect them to the resources that are there. So we do see it as a need for absolutely, and we do what we can do at the community level to aid community members in getting some sort of mental health support.
And Anna and Ling, anything else to add?
For our students, we do have mental health support as well. That we really don't do access to we don't work with the community in a way that we follow the community members. We more are kind of putting together the events and creating the opportunity for the sessions to happen. So we don't really contact the community, are in contact with the community on a longer term, more than the fair itself. But we do definitely support and really think it's important to provide access to free resources with regards to mental health or any of the screenings, because sometimes any of the resources, often the community does not have access to mental health, so to medical health at all. So we try to bring as many resources into the community as possible.
Thank you for sharing. I think I saw a question over here.
Oh yeah, you can. Okay, so I thank you to the panel, wonderful speakers. My question is, in connecting with community-based organizations, what's the best way to go? I wanted to ask this to the Reverend. What's the best way to reach you guys? Because just going to your website and seeing your name up there and then shooting an email, and I get it, everybody's busy, but how do you what's the best way that you would suggest to reach out to you, to be able to stay connected to you in order to get a call back and those kind of things?
So I'll speak for my organization and just in general as well. So through the website and the contact information, that is effective. I know that sometimes people may be busy, but we do get back to inquiries about partnerships and things like that. But also being present at fairs, like health fairs that go on. We often meet a lot of our partners that way. It's a great way to connect. With COVID, everything is virtual, but when you're in person, there is that, that face-to-face contact and that relationship bonding that starts right there as you're meeting somebody. So I would definitely suggest, being at events where other organizations are going to be represented that have similar goals and missions as you do.
Any other questions? Okay, well, if not, we are right on time. So again, I'd like to thank Ms. Anna, Ling, and Ms. Yana for joining us today. Let's give them a round of applause.
Thanks again for this insightful discussion. We're going to pull up a QR code for you to do a survey for us, because we'd love your feedback on how we can continue to improve for next year and hopefully have better weather, things that we can do better. We'd love your feedback. So if you can take out your phone, get the QR code, or for those of you on Zoom as well, we'd love to hear more about your feedback and how we can do a better job for next year.
On the scale, is 5 the best? Or 1 the best?
1. Yeah, sure.
Is that true?
Yeah, it says one.
Okay.
One is the best. And now I will invite Dr. Smith to say some final words.
Next slide.
Thank you.
No. Oh, yeah. Behind. Everyone can see me. Okay. All right. Thank you for sticking with us to the end. As we draw this enlightening and inspiring retreat to a close, I would like to express my heartfelt gratitude to each and every one of you for your unwavering commitment and to your cause for equitable cancer care. Over the course of these few hours, we've witnessed, did this one die too? Oh, we've witnessed the power of dialogue and collaboration, our discussions on creating lasting and collaborative partnerships between researchers, providers, community, and faith-based organizations, and patient advocates have illuminated a path forward, one where partnering on the path to equity in cancer care is not just a vision, but a reality. Our two thought-provoking panels, Best Practices for Community-Engaged Research and Outreach, and Community Partnerships Across New York City, have been instrumental in providing us with invaluable insights, strategies, and experiences that will undoubtedly shape the future of our collective efforts here at the Tisch Cancer Institute. I would like to extend, okay. I would like to extend some thanks to several people. First, to our exceptional guide for the day, Dr. Snow, who ensured we stayed on time and on topic. Our moderators, coming all the way from California, Dolores and Ms. Moore, thank you, and Michaelia Brown, who kept our conversations moving smoothly to ensure that every voice was heard and every idea explored. Your guidance has been instrumental in making this workshop a success. To our esteemed panelists, your expertise and insights have enriched our discussions. Your contributions have been invaluable. I'm so appreciative of the time that you've spent with us today, both here in the room, going through a monsoon, literally, and on Zoom, even those of you who joined through COVID. I'd like to thank Dr. Parsons for his leadership and Sharon for helping to fund our event today. Your steadfast support of the COE and this annual retreat have really made this possible. I also want to recognize the tireless efforts of the COE and the planning team. You know, your vision and dedication have been the driving force behind this event. In particular, I'd like to mention Drs. Mazur, Snow, Lena, who's on Zoom, Michaelia, Asher, Tatiana, and Patrick. All of the behind the scenes effort and attention to detail have not gone unnoticed. Last but certainly not least, I want to express my deep appreciation to all of you, our participants, both in person and over Zoom. Your engagement, questions, and passion for this critical cause are what have made this workshop so meaningful and impactful. As we leave here today, let us carry with us the knowledge and inspiration gained from this workshop. My hope is that we will continue to cultivate the partnerships, ideas, and actions necessary to make equitable cancer care where the voice of the community is heard as a true partner, a reality. Our collective efforts hold the potential to transform lives and communities. And I firmly believe that we can create a future where every individual, regardless of their background, receives equitable cancer care. Now, for those of you who are in the room, you've been given an index card. And for those of you on Zoom, if you could pull out a piece of paper or your phone and jot down on notes somewhere, I want you to jot down at least one action item, one thing that you've learned from today that you are going to take forward with you next week, next month, and you're going to put into practice. Just one thing, one small low-hanging fruit thing that you can do, that you can partner with someone else, that you're going to tell someone else about, that you can do in whatever role you serve to move this work forward.
And then what's going to happen is in a couple of months, because we have all of your emails, because you registered, is you're going to get an email from one of us, and we're going to ping you, and we're going to say, pull out that index card, pull out that note, wherever it is that you hid that thing, and you're going to look at it, and we're going to ask you to read it. And you're going to remind yourself that you said you were going to do that thing, because we want to hold you accountable, because you need to continue to do the work. So thank you all, and let us remain committed to the journey ahead. Thank you.
Stop the recording.